It's my privilege to welcome you all to CatchCon 2020. The theme of this conference, a state level community health department conference, is redefining public health beyond COVID-19.
I take this opportunity to invite you
CatchCon 2020. Please join us on 21st, 22nd, 23rd of
December 2020.
See you at CatchCon 2020.
We welcome you all to Ramaiah Medical College for CatchCon 2020.
Happy to welcome you to Ramaiah for CatchCon.
Let us meet at CatchCon 2020.
See you all at CatchCon 2020.
See you at CatchCon 2020. See you all at CatchCon 2020.
It's my privilege to welcome you all to CatchCon 2020. The theme of this conference, a state level community health department conference, is redefining public health beyond COVID-19.
I take this opportunity to invite you
CatchCon 2020.
Please join us on 21st, 22nd, 23rd of December 2020.
See you at CatchCon 2020.
We welcome you all to Ramaiah Medical College for CatchCon 2020.
Happy to welcome you to Ramaiah for CatchCon.
Let us meet at CatchCon 2020.
See you all at CatchCon 2020.
See you at CatchCon 2020. See you all at CatchCon 2020.
It's my privilege to welcome you all to CatchCon 2020. This conference, a state level community health department conference, is redefining public health beyond COVID-19.
I take this opportunity to invite you
CatchCon 2020.
Please join us on 21st, 22nd, 23rd of December 2020.
See you at CatchCon 2020.
We welcome you all to Ramaiah Medical College for CatchCon 2020.
Happy to welcome you to Ramaiah for CatchCon.
Let us meet at CatchCon 2020.
See you all at CatchCon 2020.
See you at CatchCon 2020. See you all at CatchCon 2020.
It's my privilege to welcome you all to CatchCon 2020. The theme of this conference, a state level community health department conference, is redefining public health beyond COVID-19.
I take this opportunity to invite you
CatchCon 2020.
Please join us on 21st, 22nd, 23rd of December 2020.
See you at CatchCon 2020.
We welcome you all to Ramaiah College for CatchCon 2020.
Happy to welcome you to Ramaiah for CatchCon.
Let us meet at CatchCon 2020.
See you all at CatchCon 2020.
See you at CatchCon 2020. See you all at CatchCon 2020.
Hello, my testing. Hello. Hello. ಸರ್ ನಿಮ್ಗೆ ಕಲರ್ ಮೇಕೆ ಕೊಟ್ಬಿಡ್ತೀವಿ ಬಿಡಿ ಸರ್ ನಿಮ್ಗೆ ಕಲರ್ ಮೇಕೆ
To CatchCon 2020, the theme of this conference, state level community health department conference, is redefining
In the month of January 2020, when we got the first case of COVID in India, we thought that COVID would come to our place also. So at that time, we started preparations on how to take care of the patient. Simultaneously, we get a lot of notices from the government saying that we should be prepared to take care of at least 50 to 100 patients in each hospital. Fortunately, at Ramaiah Hospital, we had a strong management which supported us in our initiative, as well as we had a pre-built infrastructure of 2 different hospitals. Even then, we decided that since this is an infectious case, we thought of taking a third center, a small hospital called the Ayush Hospital, which would house about 50 patients. We looked into that area. That area was not enabled with oxygen and suction. So we started enabling it at a very fast pace. In about a week's time, we had central oxygen lines put up in the entire Ayush hospital. We took over that hospital with suction and oxygen, and then we readied a 50-bedded center exclusively for COVID, which was a separate block altogether. But at that point of time, what happened was the government actually came to inspect our place, and they told that 50 bed is not adequate. We even had enabled 2 ventilators in that place. They told we should at least enable a 100-bedded hospital. So at that time, we decided that we do not know where the pandemic is going, so why 100 will enable 200 beds. So what we decided was, we have a separate hospital to take care of the middle and lower socioeconomic status, which is called the Medical College Hospital. The rare part of the hospital we identified to make it as a COVID hospital. But none of the hospitals today were built or are built to suit COVID. So we had a very tricky time now, because the hospital is not suited for COVID, but we had to make it COVID friendly. So we enabled this hospital on the rare side. So we isolated that hospital, all the corridors were blocked and sealed. Sealed in the sense, even the air sealing was done with gypsum, so that there is no contact with the rare part of the hospital with the rest. The second problem we had was, the healthcare manpower had to go through a separate route, patient had to go through a separate route. And the third issue was, the healthcare manpower which went in should come out in a different route. Fortunately, the hospital was designed in a way regularly itself, and we modified it to some level so that the healthcare people entry exit were from different routes and the patient entry exit was from different routes. Once we identified this, then we started sealing up the remaining areas, and the patients started, the entry was opened up, the door was opened up, and the patient entry exit was made, which was a different level and from a different point. And the doctors and healthcare workers entry was in the second floor, and from there we disabled the lift in that floor and disabled the lift in the basement area. So only the patient area, the lift was made operational, and the healthcare and manpower would enter there, and we created 2 donning rooms where they had to wear the PPEs, and then they should go down 1 staircase to the next level below, from where they could treat the patients. And after all the patients were seen and treated, when they exited, what we did was, we enabled a separate exit area, and then they had to take bath and go. And since large number of people were there, we just enabled 2 rooms for doffing, and in which they could take bath, 1 for male, 1 for female, and then they could exit out of the hospital. As this was being built, I just kept wondering, if the patient load actually increases beyond 200, then what do we do? Then it occurred to me, the hospital structure suited us. Only we open up both the flanks of the hospital, we could enable the 300 beds. And it actually happened, the surge happened, and we had to open up those 2 floors and on both the wings of the hospital to enable all the patients to be accommodated. We accommodated at one point of time up to 375 patients. Now the second area in logistics prior to enabling the patients was, we had only limited oxygen supply in every ward. 1 or 2 beds were oxygenated every ward. On a war footing, we oxygenated the entire hospital. That means all the 500 beds were oxygenated in a span of about 3 weeks. Once we did that, every bed could be an ICU bed. It was like that. And the second problem we had was the ICU beds, because ICU beds required additional electrical point as well as ventilators. Fortunately for us, the government gifted us 30 ventilators, which augmented our existing ventilators, and we created an existing area, modified it to enable it into an ICU level. We spaced up the bed a bit more, and put in the ventilators and high flow oxygen in that area. And the third thing we had done was dialysis. We had only 2 dialysis enabled areas in the existing hospital, so we enhanced this area into a 10-bedded dialysis center, and the whole thing was put to use at some point of time. So 10 dialysis could be done at one point of time. So that was an achievement in our hospital because no other hospital was equipped to handle so many dialysis COVID patients. So in that sense, we were very satisfied with what we had done. And once both the flanks opened up, we could accommodate 500 patients. And we ensured that all other infrastructures was in place, including food supply, had to go to some other area. All patients were supplied from hospital food. And we also enabled the physiotherapy people to get in, at least into ICU area, so that the lung complications were less. So in addition, we had a peculiar situation in the initial days wherein we had what is called as a suspect case, a case which looks like COVID, which has features of COVID with fever, lung problems, but we do not have a diagnosis. Diagnosis would take up to 8 to 12 hours, sometimes even 24 hours in the peak times. So we needed a holding area for them. So we opened a suspect ward for that, which was later linked to the existing ward so that the patients from suspect ward, if they were positive, they could just be wheeled in. If they were negative, they could be shifted to another hospital. So in such a situation, we had put up all the processes in place, all the manpower in place, and all the infrastructure in place. In fact, we merged the manpower of the nursing of both the hospitals. We identified the eligible people, about 500, 600 of them. We put them on rotation. We enabled the housekeeping also in the same way. And we made places for these people to be lodged and housed inside the campus during work. And we also made adequate provision for these people to be on quarantine later once their work duty was over. So in that sense, on all the fronts of infrastructure, the manpower, as well as the systems in place, including the flow of patients, flow of healthcare manpower, and flow of food and the supply chain, everything was made possible because of a strong management support, and we had a good cooperation from all the healthcare workers across all sections in our place, so that we didn't face much of a problem, though initially there was some resistance and some apprehension about all the manpower who went inside. Over a period of 15 days to a month, it all settled down. In fact, we were the first to experiment with what is called as the ultraviolet radiation box, and all the manpower would go in at the end of their duty, sterilize themselves, and then go off. Probably it has also reduced the number of infections in our place. Thank you.
One of the important aspects of COVID-19 management was, training of the healthcare workers. So the first thing we did was setting up a flu clinic that would segregate, COVID patients from non-COVID patients. So we set up the SOPs for functioning of the flu clinic. Then we also, trained the people who were going into the flu clinic. So the faculty, the residents, and the healthcare workers who would be going to flu clinic would have a training before going to the flu clinic. Next thing what we did was training of healthcare workers regarding the donning and doffing techniques for the PPE. So educational videos were made about the donning and doffing technique. So these modules all the healthcare workers had to undergo, and these videos could be seen by them at their convenience, and they could see it repeatedly so that they could master the technique of donning and doffing. So other thing was before going to the COVID ward, these people also would have a training session on donning and doffing. So these were the measures taken for training regarding donning and doffing. Then other important thing which was done was setting up of treatment protocols. These treatment protocols were as per the guidelines of Ministry of Health and Family Welfare. And you know that during the COVID-19, on a regular basis, there were changes in the guidelines and there were updation in the protocol. So we updated our treatment guidelines as per the government guidelines. The other thing what we faced was, many of the healthcare workers had some apprehensions regarding, doing the COVID duties. So such healthcare workers were given motivational pep talks that would allay their fears. All the residents and faculty going into for the COVID duty, they had a briefing session where they would be told about their roles and responsibilities, and they would be, all their doubts would be clarified before going for duty. Next, coming to deployment of manpower. So, for this, we needed a huge number of manpower to run the system. So nurses, paramedical staff, lab technicians, so all across the department were pulled in. All the eligible candidates who were medically fit were, deployed for this work. All the postgraduates, whether they are preclinical, paraclinical, or whether from broader specialty and or super specialty, all were pulled in for doing the COVID duties. Faculty across the departments were utilized for doing the duties irrespective of their cadre. The duties were generally 6 hours duty per day. So in 4 shifts it was there. Each healthcare worker would have a duty of 1 week. So they would do a duty for 1 week and then they would have a quarantine for 1 week. So for convenience, because we had to cater to a huge number of patients, there were 5 different teams were formed for convenience of working. So we had a critical care team taking care of the ICU. Then we had different teams, one being headed by the medicine, another by the pulmonology, another team by the super specialty, and we had separate team who was doing the triage work. One of the important things what we did was setting up of war rooms where remotely we could manage the patients. So the healthcare workers who were inside the COVID ward would clinically see the patients and talk to the patient, whereas remotely from outside, the other faculty from the different teams would monitor the patients through the war room, where they could see all their reports. They could also update their treatment chart and type the discharge summaries, and all the patient attenders were also counseled from the war room. And even the teams what we had to adjust dynamically. So whenever there was a surge in the number of patients, we had to send in more faculty and the residents for functioning of the hospital. And now when the numbers is less, we still do have a standby team so that the patient care is not affected.
During the COVID-19 pandemic, there were certain infection control measures that we followed in our hospital. One of the things were establishment of certain entry points in the hospital. So we had 2 places. We had the flu clinic and we also had the triage area. The flu clinic was for all patients, anyone who were entering into the hospital. So wherein patients were screened and it was decided upon where these patients would then go. The other was the triage area where patients who came with a positive COVID report would be categorized into whichever areas that they had to go, either into an ICU or into a ward. In addition to this, there was also set up of a suspect ward as well as a COVID positive ward. So the unique thing about setting up a suspect ward was that this was a holding area. Now patients who were suspected to have COVID but who were not yet proved to be positive would take some time for the results to come in. So these patients would not have the risk of contracting the infection. So that was one thing. Separate OTs were identified for patients who were COVID positive and also for suspect patients, and patients were operated exclusively in these areas. Now, the other thing that we needed to identify were the levels of PPE that were to be used in different areas. So we have 3 levels of PPEs, and level 3 PPE is used for patients who are COVID positive and also in suspect areas. And there were also certain key areas where level 2 PPE were required, for example, in the entry points or for lab workers or for dialysis technicians, for community workers who are going into the community for contact tracing. So these were the things that were identified, and also rational use of PPE was very, very important. And the Ministry of Health and Family Welfare gave us guidelines as to the rational use of PPE. And we also had to train our frontline workers in the process of donning and doffing, which was extremely important to prevent any kind of infection occurring in them. And we also had to identify procedures which were aerosol generating. So procedures like intubation, CPR, then patients who had to undergo surgery, then patients who had to undergo autopsy procedures, surgery. So all these areas were identified, and these were considered as high-risk procedures wherein all levels of or all precautions needed to be taken care of. And we also had guidelines for disposal of biomedical waste, which was strictly followed. And we also had an infection safety officer who would identify people who are at high risk contacts and who are low risk contacts. This particularly those patients or those people who are working in hospital areas, either in COVID areas or in non-COVID areas, and they had come in contact with a COVID positive patient, and they would be anxious to know whether they were high risk contacts or low risk contacts. So we had infection safety officer who would look into this, and likewise advise what was to be done. For example, whether they need to be tested, isolated, quarantined, the contacts, they had to be traced. So it was an extensive procedure, and many of these measures were put into place so that infection did not spread either to patients who were not positive or to the healthcare workers who were not positive. So many of these measures were followed during the COVID-19 pandemic.
The management of Ramaiah Medical College and hospitals were the first responders to this COVID-19 pandemic, and we were all geared up for this situation. We had Dr. Naresh Shetty sir, who had bi-weekly meetings with us to gear up for the infrastructure and for the manpower. Then the ball was set rolling. Dr. Harish, the leader of the core team, took this forward, and the gates of the COVID ward were open on 20th of June 2020 within 24 to 48 hours of notice. None of these staff were prepared mentally for the work. So there was some pep talk by Dr. Gurudev and Dr. Ramesh to the doctors and to the nurses, and they all got into the ward to start their duties. Initially, they had a lot of apprehension, fear, but this was set aside by the training on donning and doffing every week, which was done by some of the faculty members. Within the COVID ward, now the patients started coming in, and we had incessant calls from the BWSSB officials, from the BESCOM officials, from the fire force, police department, and so on. So we had to issue an RA number to these people because we wanted smooth functioning of the triage area with people flooding the COVID ward. So to remove that problem, we were the only hospital to issue an RA number. Once inside the ward, there was a little of a problem with the patients, and all this was done on a day-to-day basis. The core team was called as a grievance team. Whenever there was a problem, immediate solutions were given to these problems by Dr. Harish. Then there were some problems also with the BU number, SRFID. They would not bring their SRFID reports. They would not bring their BU numbers with them. And then once they are admitted, after they get admitted in the COVID ward under the government scheme, it was difficult for us to actually get them into the scheme. So after their admission, maybe after 48 hours, only then they will get their government scheme. So there was a problem with this also. So we had to actually work as a team together, all of us, including the Department of Medico-Social Workers. We all work together to see that the patients who should get the scheme should be put into the scheme. That was our main job. Next was about the management of the patients in the hospital. So there were calls regarding the condition of the patients. So 4 core teams were formed, 4 war rooms being considered. So all these, through the war rooms, we used to get the conditions of the patients and try to convey this to the patient's attendants or relatives. Later on, it was also the problem with the patients not staying back as per the stipulated guidelines. So we had to convince them that if you do not stay as per the stipulated guidelines, maybe you may not be able to get the scheme. This was also another problem that we faced. Next, when they are leaving the hospital, there was some problems with regarding to the discharges. The discharges were not happening on time, or there was a delay. So even this was also immediately promptly taken action for. And finally, the data in the hospital, it was difficult to get the data in the hospital about the total number of inpatients, where they're admitted and whether they're in the ICU or on the ventilator. So all this over a couple of months, it was streamlined, and then we had the SAST portal where we had to enter the number of patients who are admitted. So slowly things got streamlined and we were in a better position to handle the situation. Finally, when it came to the deaths, the death audit, then the SRF ID number being wrong or the BU number being wrong, Google Forms not being filled, these were the challenges that we had to face later on. Death audit also was a problem because we were not getting the requisite information, and the timely information was not there. The flow of information may have been delayed, which through experience we learned it. There, finally, to conclude, I would say that it was a exhaustive 24/7, vigilant, experiential learning, which to move ahead, now we have the COVID vaccines, so it is a lingering shadow. Thank you.
COVID pandemic has brought changes in all walks of life. New norms have been defined, new ways of living is defined. While the focus of healthcare sector is to save lives and prevent infection, we have a new threat emerging without our knowledge. That is biomedical waste. Biomedical waste, if we are going to neglect, it's soon going to be a global crisis and a big challenge to face. As we all know, the pandemic in March brought in a lot of confusion and lot of apprehension among the public as well as healthcare professionals. The quantum of waste generated was huge. So the paranoia caused increased amount of waste, not only in terms of quantity, the volume of waste also, which is one of the important challenge. The quantum of waste just not by the weight, but also by volume. This remained a challenge, especially at the healthcare sector, wherein the bins were overflowing and the collection was a big challenge. While the waste collection was not only restricted to healthcare facilities, the paranoia also shifted in the community and people started using PPE even at the household level. So the waste what was restricted to the healthcare facilities has now moved into the community. And there is another angle to it, the common biomedical waste treatment facility. The facilities are working to longer hours, and they also have a lot of apprehension as what should be the modality of treatment and concerns of occupational safety. When we look at these issues, now let's look at each of these issues. How do we address it? Now let us look at the healthcare facilities. Healthcare facilities, we have the rules in place
We have the Government of India guidelines, but it was seen that because of apprehension of the disease, the use of PPE was enormous, misused, and in fact abused. So and also the quality of waste, what is generated is most of it is plastic waste. In the process of the fear, most of it was dumped, most of it was single use and disposable waste, which increased the volume, and that went into incineration. And this could probably increase in our emissions and emissions of dioxins and furans. While the plastic waste, if you look at the PP quantum of waste generated, Wuhan studies have shown that before COVID to the current COVID situation, there was almost 6 times the increase in the quantum of waste. So the volume of waste calls for the challenge of segregation, collection and transportation, and also the management at the common biomedical waste treatment facility. So the rules, biomedical waste rules 2016 has not changed and remains the same. It's only the minor modification to suit the it's only the minor modifications to prevent the prevent the infection and also to treat the waste on priority. So the major changes was enlisted was on the having the double liners for the bins, and also labeling of the COVID waste, and also tracking of the waste by downloading the COVID-19 biomedical waste app to track the waste. So these were the things which were added on to the biomedical waste rules to streamline the COVID waste. When it comes to the community, this is one area which is going to remain a challenge, which needs to be addressed efficiently by the urban local bodies. The waste generated at the household level. It could be the general non-COVID homes or COVID isolated homes as well. We had waste generated from quarantine homes that was probably well connected by the urban local bodies to the CBWTF and was handled better. But when it comes to the domestic waste, household waste, when it comes to the biomedical waste generated at household level, the issue is the quantum of waste is less and the collection process is going to be tedious if there is no alternate mechanism which is established along with the common biomedical waste facilities facilitated by the urban local bodies. Or we are going to see the mix of waste with the general waste, and it remains a risk for the rag pickers and the domestic waste handlers. Now, next issue is the waste at the common biomedical waste treatment facility. Initially, because of the apprehension, most of the waste were pushed into the incineration. COVID waste all were pushed into the incineration. But we must remember that it's not the only solution. We have alternate solutions. Autoclaving, microwave also should be explored. And the rules very clearly says there is no need to change the process of treatment, because the existing treatments are good enough to kill the COVID virus. At CBWTF, it is important that they monitor the dioxins and emissions, dioxins and furans emissions, which is going to be expected to increase because of use of plastics, and if not properly incinerated, it's going to pollute the environment. And the other challenge remains the recycling of plastic waste, which is currently there is no guidelines, as because there is a lot of concerns and issues. There is the alternate technologies are not looked at for the management of biomedical waste. So finally, I would like to summarize with few take-home messages. Reduce, reuse, recycle remains the key principles of effective waste management system, and creating awareness at not only the community level but also at the healthcare professional level to segregate the waste appropriately, and also use PPE as required as per the Government of India guidelines which is issued, and to establish proper collection and transportation systems and track this waste efficiently. And the other important thing is to efficient management of domestic waste by the urban local bodies in collaboration with the common biomedical waste treatment facilities will be very critical. Lastly, the important message is biomedical waste and manage the waste efficiently so that we protect our environment in the long run. Thank you.
It all started last December, and now we're coming to the end of 1 year. I think this is not a historic anniversary to be celebrated. And so much things have happened in the last 1 year. The world is in a turmoil. Every country, every continent, every person is affected by this one word, COVID. Karnataka, one of the largest states in this country, has its own share. 9 lakh population have been affected, and I think almost 12,000 people have died. Our institution, the Ramaiah Medical College and Hospital, did share the brunt of this COVID. I think we treated more than 5,000 patients in our hospital itself. But that was not enough. There was a gap. Once the patient got treated, he went home, then what? And there was a big vacuum, and no one knew what really happened to these patients. And looking at what happened in Spain, Italy, UK, and we're going through the evidence that are coming in, and we saw that more problems were coming in after the COVID had actually settled down. And so that's the time when the Ramaiah group of institutions decided that we must look at a post-COVID care as one of the important segments of the healthcare. Now, when we looked at this post-COVID care, it was something new. It was the first one that happened in this state and maybe in the country. And there was no one who really dedicated to the post-COVID as much as us. Every specialty was represented, and it was a group activity that went across. And we are one of the first one who started on September 7th, the post-COVID care center, which was kind of a holistic kind of an outlook. And today, when we look after from September 7th to December 7th, we have treated more than 1,100 patients. In the 1,100 patients, what we looked at, some of the earlier data that we are getting in is almost 8% patients had cardiac involvement, right from myocardial infarction to other OQs. Almost 15% had neurological symptoms, right from stroke to facial nerve palsy. 22% patients had breathlessness. We go further, and what we saw was persistent cough was seen in 41% of this group of people, and fatigue was nearly almost in 50–60% of the patients. That was a new learning for all of us. And I think we put all our thoughts together, collected the evidence, and now started looking at what does happen to these patients 3 months down the line, 6 months, 9 months, or maybe 2 years down from the line. But what was important was most of these patients were taken care of early, and many of these patients who had muscular issues or where the fatigue was an issue, we did put them into a physiotherapy or a rehabilitation. And that actually made a difference to a significant number of population who improved considerably. And it is said in evidence also, the earlier you catch them, the better it is for the patient to return back to the normal life. That is post-COVID clinic is all about. Catching them early, treating them aggressively, and getting them back to normal life as soon as possible. Thank you.
COVID-19 pandemic. The Department of Community Health, St. John's Medical College, has been relentlessly involved in activities related to management of COVID-19 since March 2020. We work shoulder to shoulder with BBMP for contact tracing and surveillance. SARI and ILI cases admitted in St. John's Medical College Hospital and our urban and rural health centers were notified on a daily basis to KPME, SAST, Direct Surveillance Unit, and BBMP. And a unique color coding system was developed to track patient COVID status and course in the hospital. Post-lockdown, we ensured our doors remained open not only to our patients but also to those who were left high and dry for want of transport facilities and other healthcare options. We developed a triage system and standard operating procedures to ensure the safety of both patients and healthcare providers. Training sessions were held for community health workers at regular intervals. When resources were stretched thin, cloth masks were made and distributed by community health workers. We are actively participating in the fever clinic duties since its inception and managing its functioning for the past 7 months. We have managed over 13,500 patients till date by screening, testing, treating, BBMP triaging, and issuing travel certificates. Our Occupational Health Division has been conducting e-training sessions for various cadres of employees. In the hospital, we have had sessions for laundry workers, aides, and helpers. We gave comprehensive e-training sessions across India, Bangladesh, and Pakistan for textile industry workers with regard to occupational health during the pandemic. RAPID is a unique endeavor undertaken in active collaboration with 25 medical colleges from across 28 districts in the state of Karnataka. RAPID assessed the macro and micro aspects of COVID-19 preparedness at the district level. Prior to the commencement of classes, faculty and students were screened and swabbed in collaboration with BBMP. Around 500 faculty and students were swabbed in batches following strict precautions over 3 days starting 27th of November. BBMP swabbing activity was convened by the Department of Community Health with the help of health workers from Urban Primary Health Center, Madibala. Similar testing camp was also organized by our department for the nursing students. The staff clinic managed by the Department of Community Health is a unique service provided for the employees and students of SJMCH. We were instrumental in developing the interim protocols that were followed by the hospital and our outreach centers. Thank you.
I would like to talk about the Sustainable Development Goals, where we are and how do we get to SDG 2030 in the backdrop of COVID that has hampered all the progress that we have achieved in various national health programs. Yet 10 years seems like a good opportunity if we learn from some of the good experiences that are around. And I would like to share with the students, with the faculty, and all my colleagues who are participating in this conference 2 such case studies that I was fortunate to be associated with. One in the area of reproductive, maternal, newborn child health. KHPT, St. John's, and several other partners across India and the world were able to participate in a WHO-funded project on kangaroo mother care. We all know KMC, as it is called, has been there for 30, 40 years. Yet, when you look at the population-wide uptake of KMC, it's dismal. Except some tertiary institutions here and there, we never saw it more than 4 to 5%. When I say KMC, I mean effective KMC, which includes exclusive breastfeeding and more than 8 hours of skin-to-skin contact, particularly in the low birth weight babies below 2,000 grams. And the population-wide uptake was less than 1%. We started out very ambitiously 4 years ago with 4 sites in Africa and 3 sites in India. One of the sites was within Karnataka. This was led by Government of Karnataka with all the partners supported by WHO. The whole idea was, how do we take KMC to scale to more than 60 to 80% of the population-wide uptake? And we used several interesting methods: implementation research, formative research, continuous quality improvement or refinements. And over a period of time, we looked at piloting several tools, processes, and arriving at the right model. And the process, we start scaling up the model. Initially a few PSCs, then a block, then 2 blocks, entire district. Over a period of 3 years, we were able to learn a lot and refine as we scaled up. And toward the end, we were able to achieve more than 60% population-wide coverage. All this happened within the existing health systems, with Government of Karnataka leading it, similarly Government of UP, Haryana, and African collaborators out there. That is one very interesting case study where we could do things within health systems, strengthening the health systems, using evidence, scaling up gradually, and achieving population-based outcomes. Another case study, which I think is very pertinent in the context of COVID. In the COVID was a predominantly health system centered. To begin with, a public health sector centered, later private paid came in. But often the criticism was communities where needs were not in the center. Year two, in the context of non-communicable diseases in Mysore again, under the leadership of Government of Karnataka with KHPT, this was supported by Medtronic Foundation. Here, how do we bring people centricity or community centricity within the health systems centered programs? Again, there's a lot of exploration, formative research, piloting of tools, community health worker training modules, processes, use of technology, and slowly we're able to see how we can bring community needs in the center, right at the time of situation assessments, during implementation, during monitoring and evaluation. We're still early, but learnings are very encouraging. Now, what does it say? On one side, it was health systems based response, which is so important. How do we implement programs, strengthen the health systems to attain that evidence-based population-wide impact? Second, how do we put community needs in the center, looking at social determinants, gender, economy, and various other needs. And as we take stock in 2020, with 10 more years to go to get to SDG 2030, what is very important is, for the first time, the well-being is added into the SDG health agenda. It's health and well-being for all, at all ages. And strengthening health systems, bringing community needs in the center, and looking at these other best practices that are there, learning from them, and replicating it across the gamut of national programs that we have. I think that looks like the way forward to get to SDG 2030. That my key messages to all the faculty, the public health officers, managers, policymakers, and the faculty who are teaching public health. Let us look at how do we integrate health systems and community needs and make our national health programs more holistic in terms of population impact as well as social impact.
Check. Check, check. 1, 2, 3. Please. Hi, welcome back to the third day of CatchCon 2020, being organized by the Department of Community Medicine, Ramaiah Medical College. As we have announced, and as you all know, we had announced a video contest for the creative minds amongst us public health professionals. We received numerous entries, and we are going to play all of them now. The results of this video contest will be announced during the valedictory ceremony. Now please enjoy, sit back and enjoy all the 9 videos of the video contest. Thank you.
bioterrorism. It is the intentional release or threat of release of biological agents such as bacteria, virus, fungi, and their toxins to cause disease or death. Though biological warfare existed since ages, the 2001 anthrax attack significantly increased the government's funding into biological warfare research and emergency preparedness in many countries across the globe. Preparedness includes increased surveillance, increased epidemiologic investigation capacity, increased laboratory diagnostic capacity, and adequate use of technology for rapid communication. Pretty much similar to the desired approach in handling the COVID-19 outbreak. It all comes down to how prepared one is. Are we as a nation ready? As a state? As a city? Are you ready?
The first 1,000 days of life, the brain's window of opportunity. At least 200 million children living in developing countries fail to meet their developmental potential. Who has weakened this foundation? The answer is malnutrition. In history, it is undernutrition, and in modern era, it is overnutrition. Here comes the importance of maternal, infant, young child nutrition. Make sure you eat from all 5 food groups during pregnancy and breastfeeding, along with iron folic acid supplementation. Initiate breastfeeding immediately after delivery and make sure of exclusive breastfeeding till 6 months. Aware of safe and nutritious complementary feeding and continue breastfeeding till 2 years. The last but not the least, avoid junks like junk food, caffeinated and sweetened beverages. Thank you.
Appa, please, Veda. Appa, please, Veda.
Karnataka as a state is moving towards a very ambitious target of eliminating TB by 2025. It is called as Kshaya Mukta Karnataka. When I mean elimination, I mean ending TB, which is as a part of the national strategic plan to end TB by 2025. It's in line with the Sustainable Development Goal to end TB. The objective of Kshayamukta Karnataka is to reduce the incidence of TB by 80% to the baseline of 2015 and to reduce mortality rates by 90% to the baseline of 2015. To achieve this, we have in our state strategic plan 17 different activities, right from case finding to reducing the out-of-pocket expenditure among TB patients. So, when I mean case finding activity, all these days TB case finding was passive in nature. But then in our state strategic plan to end TB, we have included enhanced case finding, intensified case finding, and active case finding. So much so, we are looking to reach the unreached in the most effective manner. Apart from case finding, the emphasis is also given on case holding, both for drug susceptible and drug resistant TB. The very important aspect of Kshayamukta Karnataka is to start identifying latent TB infection and treating them. The modality of treating the LTBI is as per the WHO guidelines, and the diagnosis is through IGRAS. We also look forward for multi-sectoral involvement to eliminate TB, be it the Panchayat Raj system. We have a concept of TB elimination from the grassroots level called as Kshayamukta Gram Panchayat. On a similar note, we also have engaged with medical colleges in what is called as zero TB RHTCs. The medical colleges have rural health training centers, and we will enter into an MOU with all the medical colleges. Thereby, the medical colleges can design their own planning to make their RHTC as zero TB. So, apart from the medical colleges and the rural RDPR, we also engage with urban development. We also engage with women and child welfare and social welfare department to help TB patients in their social and livelihood mechanism. The one very important aspect of Kshayamukta Karnataka would look into destigmatizing TB. Stigma plays a very important role, especially amongst the women and the adolescent to access healthcare. And this would lead to hidden TB cases. So we would also engage and re-strategize our ACSM plans, so much so people would come forward to have access to quality health services within the public health system. This is in brief about the activities of Kshayamukta Karnataka.
Sir. ಮೂರು ಜನ ಜಾಸ್ತಿ ಮಾತಾಡೋದಲ್ಲ ಎಲ್ಲ ಮೂರು ಜನ ರಾಮಪ್ರಸಾದ್ ಅವ್ರನ್ನ ಪ್ಯಾನಲ್ ಗಾರ್ಡ್ ಮಾಡಿದ್ದೀರಾ? ಓಕೆ, ಪ್ಯಾನಲ್ ಶಿಫ್ಟ್ ಮಾಡ್ಬೋದು. ಇದನ್ನ ನಾವು ಮಾತಾಡೋದು ಆನ್ ಮಾಡ್ಬೇಕಾ ಬೇರೆ ಏನ್ ಮಾಡ್ಬೇಕು ಅಷ್ಟೇ. Okay, I see Ram Prasad, Anand is online. PS ಇಂದ 4 ವಿಜಯ್ ಭಾಸ್ಕರ್ 4:00 1 time UK is 1:30. Good morning, good evening, good night to everybody. IST. Social distancing apart. Okay. Sorry, no? No. Can the AC be switched on? Or is it okay to switch on the AC? It's behind the door.
The door be open, I think.
Yeah, it's behind the door.
Let the door be open.
Let the door be open. Yes. Audio clear ಇದೆಯಾ? Yeah.
Can't hear you. Hello, Nandkumar, I can't hear. Hello?
Sir, is the audio clear?
Now it is clear. I can hear you. I can hear you, but I couldn't hear the lady speak here. I can hear you, Nandkumar.
Only if sir joins, you tell. Check. Hello. Hello.
Yeah. Can hear you.
It's audible, sir.
Yes, it is.
Ram sir. Okay. Thank you, sir. Thank you. Yeah. No, my introduction. No, skip it. No problem. Keep it close to you.
Good evening, everyone.
evening.
Yeah.
Good evening, everyone. On behalf of Department of Community Medicine, Ramaiah Medical College, Bangalore, I welcome you all to the fourth panel discussion of CatchCon 2020, Digital India, the New Leveler. This session will be moderated by Dr. Nandakumar PS, presently working as Head, Research and Intellectual Property Rights, Division of Research and Patents, along with the position of Associate Professor in the Department of Community Medicine, Ramaiah Medical College. His key interest and expertise in the public health mathematics, data sciences and technology for primary healthcare has led to several projects and publications. He has been a technical consultant to the government and private sector in the domain of health, primary healthcare, healthcare informatics, and data analytics. Currently, he is closely working with the Karnataka state government in tackling the pandemic of COVID-19. We welcome you, sir.
Thank you.
With immense pleasure, I would like to welcome and introduce our esteemed panelists for today's session. The first panelist is Dr. Trilok Chandra, IAS, a medical doctor by training, and alumnus of Dr. B.R. Ambedkar Medical College, has held several administrative posts in the government and has brought in several reforms benefiting thousands. His efforts towards digitalization of land records has helped thousands of people in Karnataka. In the recent COVID-19 pandemic, he has been instrumental in steering the setting up of tele-ICUs and critical care centers with technology adoption. We welcome you, sir.
Thank you.
Dr. Arkulgud Ramprasad, Director, Ramaiah Public Policy Center, is a Professor Emeritus of Information and Decision Sciences at the University of Illinois at Chicago, PhD from University of Pittsburgh, MBA from Indian Institute of Management, Ahmedabad. His current research is focused on ontologies to conceptualize a problem domain systematically and systemically, ontological roadmaps and meta-analysis of research, policies, and practices in the domain. His current areas of research include healthcare, higher education, e-governance, smart cities, and local climate change. We welcome you, sir. Our next panelist, Dr. Arun. He's an alumnus of Kempegowda Institute of Medical Sciences, MD in Community Medicine, has served in the health department for more than 2 decades in various capacities, presently working as Deputy Director, E-Health, Government of Karnataka from the past 2 years. We welcome you, sir. Dr. Chandal G. He's a medical director by training and has forayed into the domain of health informatics and health administration. He is trained at the Tata Institute of Social Sciences and an alumnus of IIMB with administrative career spanning several leading e-health organizations in India. He is presently the chair for HL7 and he is leading several digital health initiatives. We welcome you, sir.
Thank you.
Our next panelist, Dr. Vijay Bhaskar Reddy. He is an associate professor at the University of Utah, Salt Lake City. He is a founding trustee of Jeev Raksha Trust at Karnataka, board member, MedTherapy, a gene therapy biotech company, Boston, USA. He is board certified in internal medicine and clinical informatics. Dr. Kandula is an expert in adult learning methodologies, curriculum design and development, systems, strengthening and institutionalizing capacity building, training and mentoring to ensure consistent and high quality training for healthcare providers. Welcome you, sir. Our next panelist, Dr. Anand Giri Shankar.
Thank you.
22 years of experience in the field of communicable disease control and public health. He is an incident director for COVID-19 response at Public Health Wales, Cardiff, United Kingdom. He is also the professional lead consultant for health protection and oversees the national operational delivery of the health protection functions of the organization. He is an expert member of Welsh Technical Advisory Cell that provides various advice to Welsh ministers on various aspects of pandemic control. We welcome you, sir.
Thank you.
Next panelist for today's session, Dr. Sudhir Prabhu. presently working as Associate Professor in the Department of Community Medicine at Father Mulla Medical College, Mangalore. He is a member of Association of Public Health Technologists and Immunization Program National Trainer, External Vaccine Monitor and Immunization Supply Chain Assessor for the 9 states of India. Also a research person for digital health, National Digital Health Mission and mobile health initiatives at interprofessional, state and national academic events. We welcome you, Dr. Sudhir.
Thank you for having me.
I hand over the mic to Dr. Nandakumar to carry the session. Over to you, sir.
Thanks, Pavitra, for that very detailed and elaborate introductions to the expert panel that we have today. And it's really an honor amidst such stalwarts who have worked in the area of health technologies for the last few decades. And we have very senior people on this panel who have been contributing both to the cause of COVID and beyond. And keeping in line with the theme of the conference that we are having, CATS 2020, redefining public health COVID-19 and beyond, we would like to see how technology has played a pivotal role in responding to the pandemic. And not just limiting to that, we also would want to see how technology would play further role in mounting a good response, which public health systems across the world are going to improve and provide better health care. So in this context, we have a very diverse set of panelists, both from governments, international governments, series from UK, and we have representation from the US. So in that context, we will, given the time that we have for this panel discussion, what I would, with the permission of the panelists, what I would wish to do is to go one round of questions specific to the panelists to share their specific expertise and how they have used or deployed technology in their own spheres of work in the COVID pandemic. And in the second round, I would request them to provide some inputs on the future deployment of similar or technologies for enhancing the care and reaching it out to the population in the at large. So in this context, without much wasting time, I would like to start with Dr. Trilok, who is a trained medical doctor, but working in senior administrator for the government, and also been involved in use of digital technology for the benefit of the masses. So in this context, sir, my first question to you would be, in the last 1 year, what has been the challenge for deploying technology, especially in the public health domain, for the cause of COVID?
Nandakumar, I can't hear. Is the audio on? Nandakumar, I can't hear.
The audio is dipped.
We can hear you, Nandakumar, but we can't hear.
Hello, is my voice audible, sir?
Your voice is audible.
Okay. Can you hear?
It would help to increase the volume a little.
Is this audible, sir, my voice?
Your voice is audible. On the other microphone, it was not very audible.
Murphy's law has kicked in.
Ram sir, can you hear now? Ram sir, you need to unmute.
Yeah, I can hear you, Nandkumar. Nandkumar, I can hear you.
Can you hear me?
Yeah, I think it is getting muffled through your mask, but you may have to speak a little louder.
Okay. So, good evening, everybody. Saying COVID-19 has presented an unprecedented challenge to the healthcare infrastructure. Can you hear now? So, good evening to all of you once again. The government of Karnataka at the outset of the pandemic realized one major challenge what we are facing is with respect to the critical care infrastructure across the hospitals. So the technology plays a real with respect to homogenizing the critical care which is available, as well as democratizing the care that can be provided across the state. As you're all aware, critical care specialists are in short supply, not only
Sir, could you hold it closer to your mouth?
harnessed, ensure that the best possible critical care which is available in Bangalore could be channelized and shared with all the district hospitals across the state where critically ill COVID patients were getting admitted. COVID actually, what I would see is initially it was thought as a public medical emergency kind of a situation. We 2 months into the pandemic, we realized from the treatment angle, what we were really missing out was the public health perspective. So the hitherto neglected or
Can the system increase the volume a little, please?
So what is the epidemiological triad, what we are initially taught in medicine? So that actually became the bulwark in preventing or controlling the pandemic as we are progressing along. The telemedicine, what we adopted was a hybrid model where the local, the unique challenge was we could not shift the patients from one facility to the another. So they had to be treated wherever they were getting admitted. But as I said, because of the shortage of critical care specialists, we had to train them and also upgrade the infrastructure. So the tele-ICU, what we set up, the critical care support unit in partnership with leading hospitals in Bangalore like Kovish, Manipal group of hospitals and Narayana Health. So each hospital, each of these hospitals were given around 10 districts across the state. They would not only advise on a daily basis, twice in morning and evening rounds as to individual case by case basis what the treatment has to be done, but also they helped in formulating the standard treatment protocol and also the SOPs for various comorbidities which the patients were getting presented with. So this really helped in reducing our CFR month on month and also upgradation of the not only physical infrastructure but also the critical care skills among the doctors and also the nursing community in each of these hospitals. So this is with respect to the critical care support unit. We harness the latest technology, all the video platforms which were available, and also with the help of some of the leading technology partners like Bosch, we could set up full-fledged tele-ICU setups in few of the districts. we could also partner with places like cloud physicians who are already in this area where they have been experienced in handling remote located critical care mechanisms. So, but also, as I said, the community medicine angle also, I think we need to closely have a look, because as we know, 70% of the mortality has been with comorbidities. So the NCD angle, how we can harness technology in not only diagnosing but also follow and effective care of them. So many of them not only realize that they don't realize that they have all these NCDs, particularly untreated diabetes and hypertension. But how do we track and ensure that they are fully compliant with the full treatment protocol? I think these are the few questions which the community health community has to apply their minds and come up with viable solutions moving ahead. So these will be my opening remarks. I think we'll take it further.
So thank you, sir, for that insights with regards to enhancing the clinical component of critical care through the use of technology. Now I would move on to Dr. Arkalpur Ramaprasad, who has been working with us in the Ramaiah Public Policy Center, and also in the last 1 year we have sort of like worked together in creating a framework for creating linkages. So Ramaprasad sir, my question to you specifically is, in terms of Dr. Trinok is mentioning about like bridging from clinical care to community, or which is the preventive care. So in that, like I would request you to throw some light on how important it is for us to bring multiple stakeholders at multiple levels of care, and how that synergy can happen through a system which is interconnected, so that like rather than working in silos, we can create a much homogeneous system for delivery of public health care.
Okay, thanks, Nandkumar. Can you hear me? Yeah. To the one way of bringing the stakeholders together and multiple levels of care would be from, you could say, my biased point of view, to have an excellent information ecology or data ecology. And we have been working with you, and we have been working with others in terms of, and recently we had a paper on a learning surveillance system for tuberculosis. So based on the work we have been doing, I come from the two areas. One is from the policy area and one from the research area. And what my observation is that in terms of really linking all these things, and if you want to link it through an information system, through exchange of data, through exchange of knowledge, what we seem to have now is a lot of data that are being collected, but there are not good databases. So there is a profusion of data, but there are no good databases in the sense of organized databases. A lot of people are keeping data on Excel spreadsheets, which are good for local work, but are bad for integration. But if you really want effective integration of stakeholders and levels, we not only need data, we not only need databases, but from these databases, we need to develop information systems, decision support systems, and the like. There are some of these things that are in place at local levels. But if the data could be integrated geographically and over time, systematically, then these information systems could have a much broader base of supporting the decisions, making the decisions, providing insights and the like. And that would be far more effective in terms of managing a pandemic like this. And here I also go into the aspect of the human-machine aspect of it. A lot of the data kept in Excel spreadsheets and the like are being processed manually. So if we can systematize them in databases and information systems, in data warehouses and the like, we would have the opportunity to automate some of these decision support and analysis and integration that can take place. And ultimately, I think it would be important for us to think of doing something that you have been doing on a day-to-day basis, that is in terms of reforming changing the guidelines, and all those types of things, the feedback and learning that is going on in a day-to-day basis. Today, that feedback and learning is going on with the help of data, but with a lot more manual computation, looking at spreadsheets and displays and what should we say, dashboards. But with the vertical integration from data to databases to information systems to feedback systems to learning systems, there is an opportunity for us to complete the cycle and make it far more effective, make it less people dependent, make it more machine dependent, so that a lot of it can be automated and be timely. So my thought in terms of integrating the stakeholders, integrating the various levels, is to create this integrated data information ecology that all the stakeholders could use at various levels of decision making. I hope that responds to your question.
Yeah. Thank you, sir. Thanks for that. So with that context, like in terms of like moving from individual data sets to databases, I would like to bring in Dr. Chandan, who is both a medical doctor and also the chief of HS7. In terms of interoperability, even with these data sets existing in silos or even in the database, unless they speak to each other, we'll be having issues of not using them for decision making. So Chandan, I would like to ask you, like, what is the role of harmonization or creating a set of standards which would help the data sets from multiple stakeholders on a real-time dynamic platform for decision making and also for assessing what has been done? Is Dr. Kendall online? Okay, if he's not, then I will not waste time. I will move to Dr. Anand Giri. Sir, in the UK, I said we heard you talk about like how technology is being harnessed for the fight against COVID. So my first question to you would be like, what are the major technology challenges in your setting insofar as handling the pandemic was concerned? On to you, Anand Giri.
Yeah, thank you, Nandakumar, and thank you for having me on the panel. Can you hear me okay? Yeah, okay. In terms, I'm just restricting my responses to the current COVID pandemic. There are a lot more wider digital challenges across the health service, and I won't go into that. So if I just broadly outline, there are four main challenges that we faced in responding to the COVID pandemic as far as digital technology is concerned. The first was we had four main focus areas. One is contact tracing, second one is testing, the third one is surveillance, and the fourth one is population level risk communication. In all of those four focus areas, we had to make use of digital technology to a large extent. And I'm just going to summarize the challenges across all those four focus areas. So first challenge we had was scalability of existing systems. So because Wales is a small country, only 3.1 million population, much of our existing systems were designed to handle data at a certain limit of capacity. The pandemic posed to us a big challenge, which was one that of scalability. Our existing systems could not handle the level of data that was coming in, so we had to think on our feet and set up new digital systems. And I can go into those later if people are interested. The second biggest challenge we found was interoperability between different systems. So in the NHS, as well as in healthcare and social care, there is a continuum, but there are a lot of bespoke digital systems. And the previous panelist spoke about having limits of good databases. So which we experienced that, and one system does not talk to another system. So the interoperability, allowing smooth data flow was a challenge. We had to put in a lot of API engines to make two systems talk together. The third challenge was, as the pandemic response unfolded, we recognized new needs for data, whether it is for mortality surveillance, for rapid surveillance purposes, and we had to be very innovative in setting up new systems. The fourth one around surveillance was mainly around population behavior. We noticed that in our first wave in March and April, population compliance to existing regulations were quite high, whereas after August, September, for reasons we are yet to understand why, population behavior completely changed. So we did not have good early warning indicators for surveillance on population behavior change. So those I would summarize as the four key challenges for us. Thank you. Back to you.
So when it comes to scale, India has always been at 10x or 100x. So I'd like to bring in Dr. Arun, who is looking at the e-health initiatives and the government of Karnataka.
Nandkumar, you have to increase the volume. Can't hear you.
Hold the mic close, that may help.
Sorry?
Better. Slightly better. Yeah, more audible.
Now we can hear you, Nandkumar, better.
So I was thinking that in terms of scale, Karnataka has always been, we have the initiatives of the Karnataka state government, and it's interesting that our saying the initial experiences of the pre-COVID and then the COVID era, so to speak. Thank you, sir.
Thank you, Anandkumar. Good evening, one and all. Am I audible?
Vic.
Okay. From the day one, when the COVID and the Karnataka first case was detected in the Karnataka government started using technology for, as Dr. Anand told, for testing, treating, and also tracking the patients. For each and every aspects of the patient, there was an app developed by the government, and we started using. I don't want to name extend in detail for all those applications, including Arogya Setu. Here, for tracing the patients and also the tracking the patients, we had Arogya Setu, and also for testing we had ICMR apps. All the detected cases were treated for the treatment, bed allotment, and also for the discharge, everything was recorded and it was made online. Apart from COVID, the government of Karnataka have established e-hospital. E-hospital is nothing but hospital information management system. It was started in 2014 and pilot basis. Now we have implemented in 47 hospitals, and also it is scaled in another 100 hospitals. So here it is a open source and it is easily customizable and it covers all the key areas, key functional areas of the hospitals. So this is the one regarding e-hospital. And at the same time, the government of Karnataka is using telemedicine, as our sir told, to utilize the to fill the gap of human resources, especially specialists, and also to utilize them optimally. We have started telemedicine. We have two types of applications. One for the doctor to doctor. That means our PSC medical officers and health and wellness center community health officer can utilize these services by contacting the specialists in the obstetrics, that is district hospitals. And another application is from patient to doctor directly anywhere from Karnataka. In Karnataka, the patient can directly contact the doctor from morning to evening. Till date, we have already given consultation for around 50,000. It's a small, it's not a small number. For the entire India, we are in the fifth place at present in giving the consultation for the poor people who are not able to come, especially in this COVID situation, who are not able to come to the hospitals. And also the old age elderly care who are not able to come to the hospital. And also for the government to government, we have so many applications like HMIS, RCH portals, which we collect the data from the periphery to make decision and also for policy making. At the same time, we are providing online services, especially for private medical establishments, for online registration and also renewal. Everything is online. The process is online from end to end. And at the same time, for COVID detection, we have an app that too from the private medical establishments. Whenever they come across any symptomatic patients having ILL symptoms, they are traced and immediately they are referred to the hospitals. So these are the things regarding the health. Apart from this, for the e-governance, we are implementing, nowadays we have started online meetings, which was not present earlier, and also online we have started e-office system. That means everything, it is transparent, accessible, and also at the same time it is fast to making the services fast for the public. This is about it to summarize this.
Thanks, sir. Thanks, sir. Thanks, sir. I typically Dr. and Dr. Sri, so that we can find the sustainable
Nandkumar, there is an echo. Please turn off. Nandkumar, there is an echo. So you may want to turn off a second mic if it's around. Yeah.
Okay. My next question is to Dr. Vijay Kandana. In the US, as a physician, what were the technology challenges that you faced during the COVID and how they were overcome? Dr. Vijay, you need to unmute yourself.
Yeah, thank you for that question. So anyway, I got my vaccine shot yesterday, in case everybody is okay. So during the peak COVID time, actually, I spent all my time in India. So even though I was following what's happening here, so I can't speak from first-hand experience as to what exactly happened here. So it will be basically from what I have read and seen and other things. So the technological challenges, the US, they have the best technology, right? At least they claim, or we think it does. I'm assuming that my voice quality is okay. Okay. But the issue here is for example, I work in two hospitals. They have a different medical record system, and each one is very possessive about their own electronic medical record. Okay, and I think it was Dr. Arklegård who mentioned about, or one of the panelists who mentioned about interoperability of data, because we have this data in silos. It is useless if you cannot compile and compute it. So you may have a good technology, but if the policies and if the framework doesn't help, then the technology cannot be harnessed to the fullest of benefit. I think we generally try to follow what the West does, especially the US. Of course, there are a lot of good things, but there are a million other things which we should definitely not copy, which is have this medical records. Each company has their own record. The government should probably, I'm sure it is doing that, this mandate that interoperability should be allowed. So technically speaking, what this means is we have to use data standards. For example, blood pressure recording. Let us take a simple thing as pulse, because to monitor COVID, what do we need? We just need 4 or 5 parameters to just to manage it both clinically and even at public health to allocate resources. We need pulse, we need maybe temperature and pulse oximetry reading, and maybe 1 or 2 other readings. If we have that, we can predict who is going to be sick. Imagine we have all this data, just 6 or 7 parameters at max, maybe even 4 is enough for the whole population. Let's take Karnataka. And if people with the pulse oximeter being in every home now, you can definitely get the pulse rate and the saturation, which is good information. Imagine having crores of that data in one place, pooling, and then you analyze, geocode it. Then you can see the magic. You know how to allocate your resources, where to move your doctors, where to get oxygen, and where to do interventions. I mean, it is fairly obvious to people in our group who play around with data. Anyway, let's take a. I mean, that definitely didn't happen in the US, But of course, they have other systems to bypass their loopholes, and but that's a lesson for us to learn. Definitely, we shouldn't copy this system. We should keep it simple. I mean, don't collect too much data and you don't know what to do with it. I mean, data should be computable so that it should serve two purposes. One, it should help in patient management. Two, it should help in decision making, that is public health, allocation of resources and epidemiology, that kind of thing. And those are my initial thoughts on this. So one thing, if I can say, is the biggest lacuna that we have in India is we have the doctors and we have the IT people, but there is nobody who talks the language that both understand. So we need to create a large pool of clinical informaticians who can talk the language of the IT people and also in a way that they understand, and similarly talk the language of the what the doctor or a public health planner needs in IT terms, so they can build the system. And that is something we can definitely copy from the US, because they have a new specialty here. It's called clinical informatics. It's meant only for people who are licensed to practice. And it was created specifically for this purpose, so that, because most of us doctors, we think the IT guys are idiots who create stuff which they don't understand our practice or workflow, and they force us to use things. So those are my initial thoughts.
Thanks, Dr. Vijay. See, in that context, probably like I'm just more than a moderator, I'm responding to your thing, because in Karnataka, at least with the people that we have sitting both to left and right of me, a lot of technology was harnessed in the pandemic. And believe me, in the last 8 months, the scalability and the number of touch points that both the government response and the multi-stakeholder response that has been done has been exemplary. And I agree with you that like health informatics is something which we need to go on. But in this context, I would like to bring in Dr. Sudhir Prabhu, who was at the front line as a community medicine person who has had the first-hand experience of using this technology for deploying at the field level. So we need a quick response from Dr. Sudhir, and so that like I can move on to the second round to get the other panelists share their next set of responses. Dr. Sudhir?
Yes, thank you, sir, for the question. I would rather add in terms of the end users of digital technologies. Am I audible? Yeah, I would rather mention the challenges, technological challenges with respect to the end users, which were mainly seen during the COVID pandemic. Let's say for the patients, the main concerns were which we could see was, say, for example, the Arogya Setu app, the privacy and confidentiality which was coming with their data going into the system. For the healthcare providers, the main issues were with respect to the case notification, which was made mandate, although they were the private providers were not mandatory reporting earlier, but the KPMEA reporting before 4 p.m. was perceived as a major technological issue, especially at the private sector level. Similarly, when it comes to the supply chain for healthcare providers, we need to know that although all the healthcare workers are digitally supported now, they have the mobile, they have the CUG SIM, the internet is free, but the communication delivery preferences, the information and communication technology, the ecosystem which they would like to prefer is something which was I felt was a bit tricky, which had to be a bit more streamlined with the technological apps and the other systems which were there. Similarly, for the health system and policymakers, there were issues, say, for example, the data which was being captured. I would like to just name a few apps like the Parihar and the Bhumi app, the contact tracing which were happening, and the follow-up which was happening for especially the mild and asymptomatic patients which were going home. So the data which was captured was not happening on the day 10 for these mild and asymptomatic cases. So if there was a cross referral, or if at all there was death which was happening in between these particular point of time, that particular thing was not being captured in the technology. Similarly, many of the government officials itself used to say that availability of ICU beds at a crucial time. Which hospital, say, I'm in Mangalore, we have 8 medical colleges, but our health officials were saying at the need of the nth hour, we would not be able to see which ICU bed, although we had so many technologies in place, but which hospital has that ICU bed which is devoted in the private hospital for a COVID patient was not known. So I would say the availability of the supply chain with the launch of Arogya Path in 13 June 2020 was indeed a very great innovation, which was launched by the central government, which ensured most of the PPE and other medicines came into the picture. With that, I would like to end my.
Thanks, Dr. Sudhir, for that quick and crisp thing. Now, I would like to come back to Dr. Trilok. Sir, in the sense like what the panelists are mentioning, one is the issue of data, the second is interoperability, scalability, and bringing multiple stakeholders onto a single platform. So we have had the experience for the last 8 to 10 months, and the acute response did have some challenges, but I'm sure like by now we have sort of like come to some kind of a platform where we can take things further. So what are the future plans and how we tend to scale it up from the government perspective, sir?
On? Yeah. I think the major challenge was with respect to technology adoption, or rather the willingness to utilize the options which are there. Though though the all the technology platforms were there, for example, the previous panelist was mentioning about availability of ICU beds, the data which should have been available. The resistance which was there from some of these setups was actually the issue. Though the platforms were there, they were not regularly updating, so that led to a lot of information lag and a lot of confusion in the minds of both the administrators as well as the general public. Though it was showing the ICU beds were available, when they went to the respective hospital, they were being turned away. clinical informatics or the healthcare informatics, I think most of the talk has been about mostly in terms of the IT parlance. I think the major challenge is the data collection, because what we from the critical care unit, what we did was, it was a lot of good papers also we have been publishing. All have been pure primary research data. So I think the user friendliness from the whatever IT platforms are being generated, that's very important, because in the mid phase, probably around June to October, there was a deluge of cases where it becomes very difficult, and the healthcare professionals also are stretched while data collection and updating multiple platforms were being used. I think that is also a challenge. I think the downtime what we have now, I think is the right time to have a very user-friendly, simple, one single interface where whatever data on the metrics which are required for a robust clinical response from not only the clinical management but also from the public health perspective has to be collected now. And a very simple interface, I think, would help a lot in not only creating a very robust database but also the decision support systems that can be put in place.
Thanks a lot, Dr. Thrillo. In that context, I would like to quickly ask Dr. Ram Prasad for creating such a sort of like interlinkages. I'm sure the learning surveillance system ontology that has been developed is going to be helpful. Can we have a quick response from you, sir, on creating those linkages?
Yeah, the linkages won't come from the ground up. We need to have an architecture for it. And somebody has to sit down and say, this is how we can bring these things together and for what purpose. I think what is lacking, and I'm not criticizing anybody, in the context of the crisis, there has been a lot of ad hoc response, local response. As the downtime gets larger, as we get over the COVID curve, hopefully, one should be able to look back and say, how do we put it all together so that we can integrate it and then actually derive meaningful information from it and meaningful value from it. But what is lacking is an architecture, and what is lacking is the force to make that architecture happen. And what that force is going to be is something that has to be determined, whether it's going to be the government, whether it's going to be the providers, whether it's going to be the institutions getting together. I think it's a wonderful opportunity, but that force has to be unleashed.
Thank you, sir. So, in fact, what I'm seeing is like the time that we have slotted for this discussion is very inadequate, and probably we might have to have it as a half a day or a one-day workshop to tease out the issues and what needs to be done. Quickly, I'll move on to Anand Giri and probably try to get some sense of response. In terms of like from the UK perspective or the NHS perspective, which apparently has a better organized digital ecosystem for healthcare response. Are there any pointers that can be taken for other countries across, Anand?
Yeah, thanks, Nanda. There are benefits of having a system which is predominantly structured around the NHS model, which is free at the point of delivery, and where there is a continuation of healthcare and social care, both under the purview of a devolved administration. So the governmental setup that is there favors such integration to happen. But sadly, I think up until now, this pandemic had not shone a light on why that was necessary. Now, ever more than before, it is necessary to do that. So, and it also leads us to this whole concept of how do we build sustainable public health informatics systems for the future, not just for COVID, but beyond. But I would just say that there are a few things that we need to consider. The first one is the recognition that digital technologies need their due share of investment in terms of its allocation of budgets. And then that comes from governmental buy-in. When people are convinced that the added value of having those systems, then it is easy to convince decision makers. To do that, you have to show and demonstrate the added value of doing having those systems. For me, the most important thing from an NHS context would be to integrate healthcare data with social care data, integrate healthcare data as itself with non-health data. And if I just give you a couple of examples to illustrate what I'm just saying. So if you, as a public health professional, advise your government or decision makers about certain interventions to pandemic, you would obviously, the next question comes is, how do you know whether those interventions have worked? What data can you provide as form of evidence? So you put lockdowns in, fire breaks in, whatever. How do you know those have worked? There are some very obvious indicators in the form of disease incidence, hospitalizations, but there are other non-health related data such as mobility data, supermarket shopping data, Google Maps, Facebook location identifications, etc., which can all be used. Social media is a powerful tool, and that can be really used for surveillance purposes to predict that. So I think the future lies in investing in digital technology, making sure that there is no silos between health, social care, health, non-health. And I think in a context of India, it is really good because there is a lot of development in the last few years about unique identifiers, whether it is the Aadhaar card or things like that, which can be used provided there is adequate checks and balances for data protection and it's utilized for the right purposes. The record linkage, data linkage can be really exciting and gives meaningful information for decision making. That would be my view. Thanks.
Thanks, Dr. Giri, for that. And Dr. Vijay, in terms of because when in the earlier discussions that we had in the last 2 or 3 months, when we looked at even the US healthcare system with some international panelists, there were gaps when it comes to public health data. While the clinical and critical care data is extremely good thanks to the electronic medical records for critical care, but when it came to public health or out of the institution data, there were huge gaps which were exposed during the pandemic. Are there any efforts at improving that in terms of public health informatics? You spoke about clinical informatics, but about public health informatics, any quick response so that we can wrap up the session?
Yeah, I hope you can hear me. Okay. So regarding clinical informatics automatically flows into public health informatics, as I may have alluded, because it has to be eventually used for clinical care and also for decision making. And the challenge here, as I said, is the systems don't talk to each other, and that has been a challenge. And that is something we shouldn't replicate. So just to give an example, for example, let us take if in Karnataka, we are able to track all the medications being sold in pharmacies. Okay, simple. And imagine in a certain geography, suddenly there is an increased purchase of paracetamol and antidiarrheal drug. Okay, so that points that people we know what symptoms they are having. And usually, if you go by the traditional method, the epidemic or the breakout will be identified a week to 10 days later. With this kind of simple tracking, just as Dr. Anand Giri said, you have to have sociological and other kinds of data. So this is just one quick example. So just tracking the sales of over-the-counter medication will help us identify an outbreak a week before the actual compared to the traditional method. So that is the power of data. If it is, I think we have ample data. Like I see many of the pharmacists have computer, they track everything, but the backend, I think as Dr. Arkalgod said, we have to invest a lot of money in that, expertise, databases, enterprise data warehouse, where all this data is compiled. Obviously, this also means that we have to have data standards, which anyway, it's part of the national digital policy. Most importantly, we need to have people who are trained, who know how to design this and how to use this. So those are my thoughts.
Thanks a lot, Dr. Vijay. In the interest of time, I would be trying to close it because I'm sure that each one of us will have more in-depth perspective and also responses in terms of how to scale up things, how to bring in that interoperability between the databases, systems, and not just locally but also globally. because the pandemic, one thing it has exposed is it's a global phenomena where what is happening in UK is affecting the person in Bangalore as we speak. So in that context, it's not limited to individuals, groups, or localities, but it's a global phenomena, and it is a technology which would help us to have a small this one like panacea to this otherwise unending problem. So in this context, I will take the opportunity to thank all the panelists who have spared their precious time, because each one of them had multiple issues and things to do. And thanks for your valuable time, sir, for having been on this panel. And I'm sure that like the discussion would not end here, and we will be required to take this important component of digital technologies in health or for health, where in the coming years we'll be seeing that it would be one of the important critical determinant. As Sir was mentioning, it is not the epidemiological triad of agent, host, and environment. The technology will become the new fulcrum for delivering optimized healthcare in the years to come. So I will try to wrap this session and probably like close the session with a small memento being handed over to the panelists who are with us here. And for the virtual panelists, probably we'll be sort of sharing the thing at a later date. Thanks a lot for your I request Dr. Lalita, who's the head and organizing chairperson, to hand over a memento to Dr. Trilok. Dr. Shalini Nui, ma'am. Arun, this one.
Dr. Shalini Nui, ma'am, I request you to hand over a memento to Dr. Arun. I now request Mr. Shivraj Anas to hand over memento to our moderator, Dr. Nandakumar sir.
Dr. Shalini ma'am to hand over a small memento to Pavitra for coordinating the event. Thanks a lot.
I guess we are done, right, Nandkumar?
Thank you.
Dear delegates, it's a very pleasant opportunity for me to connect with you and share my experiences regarding the universal health coverage and the COVID response. I thank the organizing committee of CATCH 2020 for providing me this opportunity. Universal health coverage has been a significant step, and India is a signatory to it to achieve it by 2030. This is also a part of the Sustainable Development Goals 3.8. So it is very important for us to understand where we are and how that is helping us to reach certain specific health goals and our progress towards it, and also to how it has helped in this public health emergency that every country is facing it. Health system is very critical, and the linkages between a strong and a resilient health system and universal health coverage progress has been documented well enough. And crisis has brought to its fore the critical linked relationship between these two. And even the strongest health system has struggled, but it is how you bounce back that is very important. India has made an excellent response to this crisis. And our state of Karnataka has also, though had a very bad patch in terms of the infection and the issues that it faced, has ensured that we are now stable and are able to control this pandemic. So in this small chat with you, I'm trying to explain and share with you how UHC can really help the progress of any country or any state addressing these kind of emergencies. You must be aware that Karnataka was the first state to roll out a state-wide universal health coverage. It not only covered the below poverty population, but also provided care to the above poverty population on a certain changes with some guidelines. But we were the first state to launch the Arogya Karnataka in March 2018, which was followed by the Ayushman Bharat, the central Pradhan Mantri Jan Arogya Yojana, which is the central government sponsored scheme to promote and to move towards universal health coverage. So we have a lot of positives that we can delve upon to ensure we are able to handle this crisis. So with regard to the COVID, the state response, I would like to share that though initially the state ensured that all the services would be given by the public facilities for the COVID patients, slowly the realization did happen that we need the private support. So immediately the state has been able to gather in the private empaneled hospitals under the Ayushman Bharat Arogya Karnataka program and ensure that we are able to provide both COVID testing and COVID treatment packages. So this strategic purchasing of services is a critical aspect of universal health coverage, because public sector will not be able to provide all the care it needs all the time to all the people. So we need to be very much aware that this is a partnership. We work with the private sector and ensure that we supplement our efforts to reach our goals. The second thing is because of the IT system and the kind of data management centers that was put in, we were able to have a better tracking of the response of the state in terms of identifying the contacts and also ensuring that they are given the treatment. Surveillance has a very important tool, and Kerala is one of the state which was the first to detect the first COVID case, mainly because they had a routine surveillance system to identify any kind of deviations or new cases. So it is always said that never let the good crisis go waste. So we need to ensure that this pandemic has revealed a lot of health system gaps. We need to ensure that we gear up to these gaps and address them to make sure that we build a much stronger health system. These kind of activities will always give us a lot of returns. Any kind of investment in health, beyond infrastructure development, most of the governments are realizing that investment in health is very, very critical, and it can also affect our economies. The huge lockdown that was caused because of the pandemic has clearly underlined the importance of health support systems within the country and making sure that they are strong enough to provide healthcare to everyone and leaving no one behind, because each untreated case could also be a potential spreader. So it is important that how we are able to ensure that these kind of health system efforts are made strongly to underline the resilience, the critical nature of our health systems, the service gaps, and the political leadership. So the governments which had a strong political leadership also showed very much better response to this pandemic than other countries.
As we all know, we are in the pandemic of COVID-19, and it all started, I think, in month of March, by first week and second week. Until then, we were only as spectators watching different countries, what's happening, and we were just thinking, okay, this is happening, that is happening. But when the actual time came, we were almost unplanned, unprepared situation, and we didn't know in what direction, in which direction, how to move and what has to be done, whether we are right or wrong, and it was totally unorganized. But anyway, to say that word unorganized, maybe I could be wrong, but I can only say that our administrative capacity of Karnataka was excellent, and not only from the commissioner level or the deputy director level, it is from right from the health minister to chief minister of Karnataka. I can say we had a very, very good connectivity and understanding how to address the situation, how do we go about it. So it was done in a very, very massive way, and very aggressively we all started functioning by recognizing the nodal officers to work. So likewise, we had 4 nodal officers to take care, we were called as a cluster heads, and we had cluster head for the government institutes, we had a cluster head for the private hospital, and we had a cluster head for the medical colleges. So we had 4 cluster head where would be the nodal or first point of contact for us to address and how do we go about it. So my role was as a cluster head to the private hospitals. As we know, Bangalore urban is highly dense with more private hospitals, but they were unfortunately not empaneled with us earlier with the SAST. So overall, we had about 320 hospitals. In that, we segregated daycare centers and clinical centers which used to provide only OPD services. So totally, we had about 118 hospitals in Bangalore urban itself, which were not empaneled with us. So we relaxed in our empanelment criteria. So we made auto empanelment, and thus many hospitals came in. So we had about 118 hospitals to provide COVID services following the guidelines. And this was again further categorized above 100 bed capacity and 100 to 50 and below 50. So these hospitals were called upon to be compliant with us to provide the COVID services. But anyway, to begin with, they were not well prepared. The reason is because of the costing and the payment. So, and the empanelment criteria. During the pandemic, it's just a team effort and one of the wonderful, amazing human touch done by all the levels of administrators, right from our CM to the least person of the group D, I can say, even including the ambulance drivers and the medical fraternity and non-medical fraternity also, who have done a wonderful job during the pandemic. Thank you.
May I request the other panelist, Dr. Hello, am I audible? Yes. Can I request Dr. Farah, Dr. Rizwana, Dr. Subhash, and Dr. Praveen to switch on their video too? Am I audible to all of you?
Yes, you are.
Yes, ma'am. Dr. Rizwana, I am able to hear you. Dr. Farah?
Yes, Suman, I'm able to hear you.
Yeah, I am able to hear you too. Dr. Subhash? Dr. Praveen?
Hello, ma'am. Am I audible?
Yes,
Yes.
Thank you, Dr. Praveen. Dr. Subhash? Dr. Subhash, are you online? Are you able to hear me? Okay, in the meantime, let me introduce all the panelists to the rest of the delegates who are here. Good evening, ladies and gentlemen. Welcome you all for the last of the academic sessions, last but not the least of this conference, that is implementing competency-based medical education curriculum for the undergraduate students, the challenges and the way forward. And the panelist, it's a pleasure to introduce the panelist for this session, Dr. Ranganath, who's a senior MCI SSS since 2009, Board of Studies chairman for the postgraduates as well as for the undergraduates at the Rajiv Gandhi University of Health Sciences, curriculum committee member of RGHS for both postgraduates as well as undergraduates, professor and head, Department of Community Medicine, Bangalore Medical College and Research Center. The next panelist is Dr. Rizwana. She has more than 20 years of teaching experience, of which 10 years is an integrated organ system-based curriculum, a graduate, MBBS graduate from Bangalore University and an MD from Kuvempu University. She's also a graduate diploma in health profession education from the Gulf Medical University. She was an associate dean, assessments and evaluation and coordinator MPH program at Gulf Medical University. She's currently medical advisor of the MPH program at the Gulf Medical University and is working with Karnataka Institute of Medical Sciences, Hubli, as an assistant professor, community medicine, and also the member secretary of medical education unit. And she has a keen interest in curriculum reforms. It's a pleasure introducing my colleague, Dr. Farah, Associate Professor, Department of Community Medicine, St. John's Medical College. She has been awarded a lot of awards. Just to name a few, she was a California Global Health Institute Fellow, and she has also got the Best Innovation in Diabetes Care Challenge in Challenging Situations in 2020. That is RSSDIUSV. You may ask her the full form when she's on the panel and if time permits. She is a member of the Medical Education Department at St. John's, which is a regional training center by the MCI. It's a pleasure to introduce Dr. Praveen, Associate Professor, Dr. Praveen Kulkarni, who's an Associate Professor, also a FAMER Fellow. He's a member of the Integration and Alignment Committee in JSS Medical College. And Dr. Subhash Babu, who's also an Associate Professor from Mandya Institute of Medical Sciences and the member of Curriculum Committee. So can we start off with the panel discussion? Dr. Subhash, are you online? Are you able to hear us? Dr. Praveen Kulkarni, welcome.
Hello, ma'am.
Hello. Dr. Subhash, I'm not getting a reply from you.
Ma'am, Dr. Subhash has sent a message that he's not in a position to listen to anything and his voice is also not audible.
Okay.
Yeah, I think we can go ahead.
We can go ahead. I hope he will resolve the technical issues and join us shortly. Subhash, we are looking forward for you. All right. Most of us know that the CBME was introduced last year, and there were a lot of new things that this curriculum had brought in. Now, for most of us, we have finished the first year subjects. The newer ones that was introduced were the early clinical exposure, the foundation course, and also the ADCOM, which would be running parallelly with all the other things. So when it comes to the second and the third professional years, we have the newer ones that are here is the certifiable skills. Of course, certifiable skills were also there in the first year. And the duration for the second professional year and the third professional year have been reduced. However, the total duration of MBBS more or less remains the same. Now, this has thrown up some of the challenging situations for most of the faculties in both government and private colleges. And of course, implementing this has challenges both in terms of infrastructure, training of the faculty members, and also trying to set up all these things. So should I call it as man material and manpower and all of these things put together? So some of the challenges most of us would agree is the first one is to create a timetable which would have been integrated and aligned. Most of the time, we have always had departments working in silos and trying to concentrate on what needs to be put across or the must-know areas for their departments. Now, it's time that the departments and the specialists come out of their comfort zone and try to communicate and coordinate with the other departments. I'm sure this would have thrown up a lot of interesting challenges, I should say. Can I request Dr. Farah and Dr. Rizwana to comment on how did they go about integration and alignment of the timetable? Dr. Farah? Ma'am, we are not able to hear you.
Dr. Rizwana, please unmute yourself.
Yes. I realize that. I think Dr. Farah is having some problems with. Okay, yeah, we have her back. Yeah. I think Dr. Farah can go with it first because I'll be sharing my experiences as to how we went about. Dr. Farah? I think there are some issues with Dr. Farah's connectivity. Okay, just to tell you that when we plan alignment and integration, we first have to unlearn what we have done so far. That's the most important thing, because unless we unlearn, because the general tendency is to go ahead and do it the way we have been doing it. So unlearning that process and redoing it entirely, and it's not one department that can do it. It has to be.
Suman, can I talk, Suman?
Yeah. Dr. Farah, you can go ahead.
Yeah. Speaking.
Please go ahead, Dr. Farah.
Ma'am, I can't hear you very clearly.
For Dr. Rizwana is clear for us. Farah, are you there?
Okay. Suman, can I go ahead?
Yeah, please go ahead.
Yeah, please. Oh, sure.
Farah, I can't hear you, Farah. Ma'am, Rizwana, ma'am, can you please?
Yeah, let me go ahead till Dr. Farah joins in. I think all the departments sitting together and doing that is the most important thing. And what we did was, I told you I was in an organ system-based integrated curriculum. So one major subject in each phase was asked to make the timetable first. Like, say, pathology. In phase 2, if I take phase 2, pathology was asked to make the timetable. And then they have general pathology, and then the organ systems come. So while pathology was doing the organ systems, the general pathology, the other subjects also did general pharmacology or microbiology, and all of that was finished. And once this organ system started, like say if respiratory system started, The other subjects like microbiology brought in their respiratory organisms, and then pharmacology brought in the medications, and the alignment of topics happened there. So if you take community medicine, now we have in phase 2, we have occupational health. Suppose we want to discuss pneumoconiosis. It would be best to align with, when pathology is doing respiratory, system. At that point of time, we bring in our pneumoconiosis and our, occupational health. You try to align it at that point of time. And vertical integration is a little easier. You bring in a case and your vertical integration happens quite easily. So that was how we went about it, when we planned our alignment and integration. So we really need all the departments to sit together and do that. It cannot happen in isolation. And like in phase 3, it was internal medicine who was given that they plan first and then everybody integrates along with them, aligns and integrates. Likewise in first year, phase 1. So that's how it has to go about. Even I was waiting to listen to Farah as to how they went about with integration with this timetable that they were creating in RGHS. So if any other member was there from the panel, they could,
Yeah.
throw light on that.
Thank you, Dr. Rizwana. That was really nice. I'll hand it over to Dr. Ranganath. I think he can give you a overview in terms of how RGHS colleges would have gone through this timetable for the second and the third professional year. Since the first professional year is already over, and we are moving on to the second, and we also have to plan for the third very shortly. And our subject spans from first, second, and the third, including the internship. So I'll hand it over to Dr. Ranganath for his comments.
Yeah. Thank you, madam. Now, in the medical colleges, now the CBME, as far as CBME is rolling out now, now in the medical colleges, the CBM is rolling out from the first profession to the second profession. Now looking for this, the number of hours the community medicine supposed to be taught. The number of hours the medical colleges has to teach, if you look at this compared to the earlier now, there is slight reduction in the teaching hours in the lecture hours. They made 1/3 as a lecture, remaining 2/3 is a practical part. So we should, as Dr. Rizwana was telling, we should sit with the other departments and you have to take like pathology, microbiology and other things that we have discussed. The Rajiv Gandhi has made this committee, and with this we have discussed the specialist in the different subjects, and the timetable is framed like a block 1, block 2, block 3, and how the community medicine should be placed in a first block or third block or something like this to complete the. In the second profession, total hours is 60 hours supposed to be teach the community medicine to the undergraduates regarding what all the skills and other things required. So that is is already submitted to the Rajiv Gandhi University. Similarly, final year is a major along with the forensic medicine and medicine surgery OBG. Total is 105 hours supposed to teach the undergraduate students as per National Medical Council, and the skills and the competency, all those things have to be done. So that is due process. But the challenge here is to coming in contact with all the departments, and everybody is fighting, we need the convenient time in this and that. So that is a one issue. But we can, if we sit together and we can make the timetable. So that is not an issue, because now the number of lecture hours are reduced, small group discussion, practicals are there. So that is quite possible. Now the committee has submitted the second profession timetable to the Rajiv Gandhi University. Thank you.
Thank you, Dr. Ranganath. One more question to you. So the timetable that has been provided, all the medical colleges under the RGHs have to agree to it.
Yes. Yeah, because now if I am right, in Karnataka, 56 medical colleges, of that 36, if I am right, 36 medical colleges comes under Rajiv Gandhi umbrella. So all those has to follow the skeleton we are given. So like in the second profession, total teaching hours is 20 hours as a lecture, 30 hours as a practical or a small group discussion. Suppose if a Ramaiah College or Bangalore Medical College about 150 or 250 students, that has to break into the convenience, maybe about 30, 40 or 50 a small group, and that has to be taken by the residents or faculty or senior faculty, everybody. So that has to be taken.
Thank you, Dr. Ranganath. Dr. Ranganath, just to apprise everybody, Dr. Ranganath was telling that all the colleges under RGUHs have to align to the timetable that has been provided. They can have their little adjustments within them. One more issue, what most of us have faced is there are with the CBME, when we have to concentrating on the competency based, then we need to concentrate more on the different teaching learning methods that have to be looked into. As the timetable proceeds, most of us have seen that the hours in didactic lectures have to be reduced and more number of small group teachings and experiential learning is something which has been emphasized on. Dr. Praveen, I would want you to comment on what new small group discussions or small group teaching sessions can be adapted. Dr. Praveen, can you comment on this?
Yeah, thank you very much for this question. So there is a total paradoxic shift as far as CBME implementation is concerned. We used to have so much of luxury in teaching the students with the large group teaching sessions. I have seen the timetables in different colleges. There will be one complete hour lecture on leptospirosis. There will be one complete hour session on, there will be 3 sessions on tuberculosis, okay, 3 lecture sessions on tuberculosis and 4 sessions on something else. So we do not have so much of flexibility as per the large group teaching is concerned. We need to adapt ourselves to the small group teaching sessions or small group methods. For this, we need to have an array of small group teaching methods. To start with, we can start with a group discussion, okay, which is the most simple form of small group discussion. The other ones can be problem-based learning. Problem-based learning sessions can be more effectively utilized. We used to give epidemiological exercise to the students. So we do not have so much of luxury of having 3 sessions on tuberculosis for the lecture. So what we can do is we can have one small introductory lecture on tuberculosis and dedicate rest of the things on tuberculosis to the small group teaching sessions. Okay, so like problem-based learning is one, other could be the team-based learning, other could be the case-based learning. Case-based learning is the one which we usually do in medico-social case presentations. What we are trying to do in our university is the hypertension, diabetes and all these non-communicable diseases, which we are definitely going to cover in the case-based learning, that is medico-social case presentation. We are giving little emphasis on them in the large group teaching sessions because most of these components will be definitely covered in the case-based learning. So case-based learning is one of a very important strategy that we can adapt. And we have other small group teaching sessions like why can't we use flipped classrooms, which is another important small group teaching session method we can adapt. We have something called a jigsaw learning sessions, where I think most of the places where I go as a resource person and most of the people here, they have really worked on jigsaw learning, jigsaw method of teaching, and we are adapting it over a period of time. Mind mapping, or what we call as a concept map. Concept map is a very interactive way of learning through the small group teaching sessions. Okay, so we have something called as a fishbowl technique. Fishbowl is very commonly used when we are having the focus group discussion related topics and when we are talking about something where there is a sharing of experiences. So these are an array of small group teaching sessions that we can adapt. And if the small group teaching session, people will really think that, okay, only we'll have a group discussion and we'll finish off. So if you provide, kind of variety to the students are definitely going to enjoy the teaching learning methods and they are going to definitely come out with more ideas, and it is all beginning and over a period of time we'll learn the things. Thank you.
Thank you, Dr. Praveen. Ma'am, Dr. Farah, are you there?
Yes, Suman, I'm there. Sorry for the technical glitch. For some reason, I was not audible.
Thanks for coming back. Okay.
So,
The small
Suman,
group sessions is something. Yes, Dr. Farah.
Thank you, Suman. I totally agree with whatever Praveen has said. I think we need to um, according to the new curriculum, only 1/3 of the current teaching methods will be lecture based, and 2/3 is going to be in the form of small group discussion. So this is one of the main challenges which all faculty members are going to face, and it's time for us to think outside the box and think of newer methods. One main thing I think is we should move away from the need to cover all the topics and to cover everything in that topic, and from this move over to focusing on the outcome. What does an Indian medical graduate need to know from this topic, and then plan our teaching learning methods accordingly. So Dr. Praveen has very nicely illustrated all the different newer teaching learning methods which are available, from flipped classroom to fishbone technique to a jigsaw method. Also, we could use simple things like case-based studies, videos, role plays, in which the student involvement is more. So it's not just about finishing off all the topics. Even in the topic, focus on the specific learning objectives, and that's how I think we will need to go. Another important challenge which we'll be facing is the number of hours. Under the old curriculum, community medicine had a total of 369 hours that were available. But in the new curriculum, CBME, we have only 217 hours. So the total number of hours available to us have been reduced, and we'll have to plan our topics in such a way that we make the best use of the available time. Even in these 217 hours, 52 hours are in the first year and 60 hours are in the second professional year. This is the time when more than half of our syllabus or the specific learning objectives or the competencies will have to be attained. So that's one thing which we'll have to keep in mind.
Yeah, thank you, Farah, for that. Can the teaching learning methods are very nice, and then there is right now we have a list of things that can be implemented, but assessment also plays a major role, and this is what drives learning. When it comes to assessments, even the CBME says emphasis more on the formative assessment also. So I feel that is a challenge when it comes to assessing the formative assessment. Can I have Dr. Rizwana and I hope Dr. Subhash is there. Are you there, Dr. Subhash? Okay, can I have Dr. Rizwana comment on this? How do we go about addressing this issue of including the formative assessments in the curriculum?
Yeah, formative assessments are basically to give feedback to the students. And here we can see that our formative assessments feed into the internal assessments also. So if you see the internal assessments as such, you have the theory, the practical, the logbook, LATCOM, and all of that. For community medicine, already we had a whole lot of, teaching learning methods that we had. So we had seminars, we had field visits, we had clinical social case discussions, and we had family study, we have communication activity, and a whole lot of teaching learning activities. The thing is that we also had built-in assessment in place in most of the cases. Like we had at the end of clinical social case discussion, the student did maintain a log and the student a diary, a practical record book, and we did have assessment at the end of it. Now, for each one of these activities, what we can see is now it has to be planned, streamlined, and structured and documented, assessed, and graded. So what was happening this till now was that we were having all of these teaching learning activities. We were also assessing it to an extent, but it was not documented. It was not graded, and those grades were not again documented. So eventually, having all these teaching learning methods and having all this assessment without any grading strategy, it all goes to waste. So every formative assessment that we have, like say we finish epidemiology and we have a class test at the end, have it graded and have those marks there. And then if we have a clinical social case discussion, those grades there, seminar, have a rubric for that, assessed, and have it there, documented. So once we have, I saw the draft copy of the logbook, and I think the team that has put together the draft copy has done a very good job. So we have all of these formative assessments there. You can see it in the logbook. So I think what is required is the streamlining. As you said, rightly pointed out, Dr. Suman, that assessment guides learning. So the students have to be told that every little activity or every little assessment that they are going through, this is, going into the formative assessments, and, they have to be given a feedback, yes, but also that these grades are feeding into the internal assessments also, so that they take it seriously. So everything has to be streamlined, structured, faculty training for that, students have to be oriented about that, and I think that's what is required as of now.
Thank you, ma'am, for that excellent overview that you provided regarding the formative assessment. It means that the faculty members have to dedicate, and a lot of time needs to be spent in terms of streamlining it. The ball is set rolling from the first professional year. So the second and the third professional year, faculty members need to start thinking in those terms and looking at it from that angle. Going on to one more aspect that we have AdCom here. It's a well-structured document. Most of us have gone through it. But when it comes to certain aspects in terms of how do we assess whether the student is really doing this or not, I feel that is a challenge for us. I'll hand it over to Dr. Ranganath if he has any suggestions or comments, or how do we go about addressing this issue.
Yeah, thank you, ma'am. So this AdCom is that's attitude, ethics, communication, skill. This we all know this as per GMR, Graduate Medical Regulation Act 2019. The NMC says in India, Indian medical graduate, you should have 5 competencies, like you should be a clinician, you should be a leader and member in the healthcare team, and we should produce the Indian medical graduate should be a very good communicator, and you should be a lifelong learner, and you should have this a professionalism. So to maintain Indian medical graduate with these competencies, a module called as AdCom skill is required. So that's what I believe personally. Maybe that's why we get beaten by this healthcare personnel or ransom in hospitals and nursing homes, something like this. So this type of it's a longitudinal modular. A medical student, once admitted in a first profession, second profession, we should introduce slowly with respect to the communication required for that. So that an undergraduate should understand and apply the principles of bioethics and law in a medical practice. The undergraduate student should be also able to understand and apply these principles of clinical reasoning in the healthcare of the patient. He should be understanding the empathy and human values to the care and effective communication, either breaking the bad news or about any other good doctor-patient relationship at all. And there are so many such skills. So this outcome, it is a different topic, and now so the teachers, we have to attack them in a different pace, maybe about teaching or role model or charts, so many other case-based learning, something you have to take them. So the NMC has introduced, and it is of course it is a bit challenging in the existing short timetable where you have to include, how to include. So that is the challenging, but the expert have to sit and which skill has to be taught in which profession, and with a scenario and other things are, it's very good. If at all, then I think it will be a very good outcome, so that as per NMC recommendations, an IMG will be perfect.
Thank you, Dr. Ranganath. To conclude this, the take-home messages I have is all the faculty members Dr. Angadi is here with us. He would like to share something.
Professor Dr. Angadi, he's a professor HOD in Sridevi Medical College, Tumkur.
At the outlook, I say that competency-based medical education is a very good thing, but in practice, because there are very shortage of staff members in most of the medical colleges, in that case, how to go for small group discussions. As well, there is a lot of difference in the salary from the private to government. What should be done to make it, these two issues are there. How you have to proceed?
Sir, thank you very much for that. I knew this topic would definitely come out in this panel discussion. This has been discussed at length in various forums. My take on this would be is to use technology appropriately. And this COVID situation has definitely taught us how to use it. It has forced us to learn technology, use online aspects, online platforms for us to communicate these things. I think a blend of these two should help us iron out the shortage of the faculty members, as you said. Training of this, yes, it's going to take some time, but I feel we will definitely achieve it, is what is my take on it. So to conclude this panel discussion, after hearing to Dr. Rizwana, Dr. Farah, Dr. Praveen, Dr. Ranganath, Dr. Angadi, unfortunately, we were not able to hear Dr. Subhash. The faculty members have to come out of their comfort zone, collaborate, coordinate with all the other departments within the departments, think out of the box for newer solutions and innovate either newer methods of teaching learning or assessment methods to implement the CCME for this undergraduate. Surely, shortly, we may get postgraduate also. So we need to start thinking in that direction and start implementing this. And I thank all the panelists for participating. I'm sorry for the technical glitches what we had initially. Thank you all.
Thank you, Dr. Simon.
Thank you, ma'am. Dr. Rizwana. We would move on to the next aspect of this program, that is a valedictory function. In the meantime, we'll have the catch talks that would be videos of the, yeah, I'll hand it over to Dr. Anand to give the next thing.
Am I? Am I audible? Audible? Yeah. Hi, welcome back to CatchCon 2020. That was such a beautiful discussion, which was very relevant. And also, I hope that the participants and the delegates who have joined us have gained a lot from this discussion. So continuing, as part of this CatchCon 2020, we had called for exciting and innovative videos as part of a video contest. This was one of a kind in CatchCon, and we got tremendous response. We got 9 videos from across the state and outside the state also. I would like to present all those 9 videos now. We'll be announcing the winners of the video contest during the valedictory. So please enjoy the 1-minute short videos.
Please better. Please better.
Sometimes there is a simple solution for a big problem. Whole of the medical fraternity and most of the general public know that precaution is better than cure. Wearing masks, social distancing, and other measures like hand wash can reduce the risk of coronavirus transmission, but it does not prevent the virus from entering into the body. This RNA virus usually enters the body through nasal and oral cavity and then enters into the cell and proliferates. It takes about 2 to 3 days to produce the clinical symptoms. Regular steam inhalation and gargling prevents the growth of the virus in mucosa. Take care while handling the vaporizer. Deep inhalation helps the steam to act in the paranasal sinuses. When you do it in the right way, progression of the disease and its complication can be prevented with certainty. Why am I so stern about this? It is because I have observed in close quarters my friends and family who have followed this regimen regularly since the start of the lockdown, and none of them have been tested positive in spite of high professional risk.
ಒಳ್ಳೇದಾದ್ರೆ ಅದು ಮಾತ್ರ
Welcome to CD Signer.
Bioterrorism. It is the intentional release or threat of release of biological agents such as bacteria, virus, fungi, and their toxins to cause disease or death. Though biological warfare existed since ages, the 2001 anthrax attack significantly increased the government's funding into biological warfare research and emergency preparedness in many countries across the globe. Preparedness includes increased surveillance, increased epidemiologic investigation capacity, increased laboratory diagnostic capacity, and adequate use of technology for rapid communication. Pretty much similar to the desired approach in handling the COVID-19 outbreak. It all comes down to how prepared one is. Are we as a nation ready, as a state, as a city? Are you ready?
1,000 days of life, the brain's window of opportunity. At least 200 million children living in developing countries fail to meet their developmental potential. Who has weakened this foundation? The answer is malnutrition. In history, it is undernutrition, and in modern era, it is overnutrition. Here comes the importance of maternal, infant, young child nutrition. Make sure you eat from all 5 food groups during pregnancy and breastfeeding, along with iron folic acid supplementation. Initiate breastfeeding immediately after delivery and make sure of exclusive breastfeeding till 6 months. Aware of safe and nutritious complementary feeding and continue breastfeeding till 2 years. The last but not the least, avoid junks like junk food, caffeinated and sweetened beverages. Thank you.
I'll take you through our scheme, which is the integrated Ayushman Bharat. Scheme came just a few weeks before the Ayush. In October, Karnataka found that the vision of both the schemes, which is to reduce the out-of-pocket expenditure due to hospitalization, this was the vision of both the schemes. So the Ayushman Bharat scheme and the Arogya Karnataka scheme were integrated, and it was launched on 30th of October 2018. And this was a flagship scheme of the state to decrease out-of-pocket expenditure due to
the number of members who are present, whole family will be covered with a maximum amount of around 5 lakh on a floater basis per annum. So, and in case of APL family, around 30% of the
Good evening, everyone. As a representative from the Department of Community Medicine, Ramaiah Medical College, I, Dr. Pavitra, take this opportunity to welcome all the dignitaries who are present here, and also to all those who are watching us online. I welcome you all to the valedictory function of CatchCon 2020. I request all those who are gathered here to raise for the Ramaiah anthem. Shri
ತಂತ್ರಜ್ಞಾನದ ಸಮಪಾನವಿದು ವಿಧಿಯಿಲ್ಲದ ಅಮಿತ ಜ್ಞಾನತೆ ಸಾಧನ ಕ್ಷೇತ್ರವಿದು ಪ್ರತಿಭೆಯ ಸಾಧನೆ ಮಾಡಲು ಸ್ಫೂರ್ತಿಯ ಕೇಂದ್ರವಿದು
Thank you, ma'am, for giving us the overview of the proceedings of the last 3 days. Moving ahead, now I request Mr. Javed Akhtar, Sir, IS, Additional Chief Secretary to Government of Karnataka, Health and Family Welfare Services, to release a souvenir of CatchCon 2020. Thank you. Now I request Javed Akhtar, sir, to address the gathering.
Very good evening to all of you. At the outset, I will express my gratitude and thanks to the organizers of CatchCon, uh, this Karnataka Association for Community Health's 32nd annual conference, for inviting me here this evening. Thanks to all of you. This conference is being organized in a very different time. As it has been indicated, usually the conference happens physically, and the COVID has forced the world to change its ways. And as very rightly said, we have also discovered certain benefits of it. For example, if you organize programs online, then people from far off places are able to join without much hesitation, without much problem. So as it was revealed this afternoon, I am told that two speakers joined from USA. So that type of thing does not become possible, and it permits actually larger number of people to participate. The picture is not very good because you will find very few people sitting somewhere and talking, but overall benefits are no less. In government also we have discovered the benefits of video conferencing because now we are able to organize larger number of meetings and where deputy commissioners, superintendents of police, they join from faraway places. Government of India is able to organize meetings where people from across the state at senior levels are able to join. Earlier, what used to happen that in a meeting which was called in Delhi, I mean, senior representative from 5 to 10 states used to come, and others who used to be very junior officers because it is not possible for so many people to go at one place at a particular instant of time. So, and the best thing about this is that this is a hybrid program. So I will really commend the organizers of the program to have the benefit of best of both worlds, best of both the ways, online conferencing as well as physical presence. So having said so, I will not take much time because all of you are seeing what is happening in this COVID-19 situation in Karnataka and outside Karnataka for a long time. Now we are going to complete 10 months of it. It is a very long time. Earlier we were thinking that we are bogged down to a situation for 3 months. Then 3 months got extended to 6 months. It is never ending. Now we realize that it is not ending. Every week or every month something new crops up and that keeps us busy. Even if things are not very difficult, but at least you have to think about it and find out ways to manage and counter it, as it has been seen yesterday. Because now the international flights have been stopped because there is a fear of a spread of this new mutant of UK. I don't know whether any name has been given to it or not so far. Names are also difficult to remember in this, especially viruses. so so in Karnataka, we approached a very simple method. We realized that this is going to be a huge problem. We expected the problems to be massive. When the first case was found in Karnataka, by that time, we had examples of countries like Spain, South Korea, Italy, etc. So we sat down at that point of time and tried to assess the capability that we have. Because in Italy, the peak was some 86,000 cases. And we tried to compare because Italy is a country as big as Karnataka. So our first contingency plan that we prepared in the month of April, it took a cue from the numbers found from Italy. That country was having the maximum number of cases at that point of time when we prepared our contingency plan. So we started preparing ourselves to handle about 1 lakh patients. What we did, we leveraged the expertise which was available, the schemes which were available, and efficient personnel which were available with the government and outside it. One is that we created a structure because this was going to continue for a long time. So we created structures. The one structure which was created was Technical Advisory Committee. This was something new. Nobody was knowing what to do. Therefore, there was a necessity that experts sit, gather information from across the world, study what is recommended by WHO, Government of India, what other states, other countries are discovering, bring that knowledge together and advise us. The first such committee was constituted in the month of March itself, early March, that is now forgotten, the first committee. Subsequently, we also realized that apart from giving us advice on epidemiology, how to contain the spread, how to do contact tracing, how to quarantine people, there is also a need of clinical treatment. So we constituted the second committee, that was Committee for Clinical Protocol. That is headed by, this committee is still continuing. The first committee is forgotten because a larger committee was constituted subsequently. The first committee headed by Dr. Sachidanand, it is still there. Thereafter, we constituted a high-level committee for technical advice under the chairmanship of none other than Dr. Sudarshan, who happens to be one of the founders of CATCH. I'm privileged to have him here. Another glittering star of that committee is Dr. Ravi. So, so he was there. So we selected the best expertise which was available with the government, outside the government, and all these structures that we created, a framework was given, and it was a very flexible structure. So some point of time in a meeting, there used to be 5 persons, at other time 15, 20, depending on the requirement. So we made this very flexible. That was one thing. So this gave us very efficient, very, advanced and very up-to-date technical advice, both for tackling the disease and both for treating the patients who are hospitalized. Another thing that we did was that we divided the work into various groups and appointed nodal officers. So teams were formed for, and those were headed by very senior officers looking after quarantining, contact tracing, etc. So like this, number of teams were constituted depending on the requirement. There was a time when we were supposed to screen all the air passengers. So a very senior officer was devoted for that. He sat at the airport, coordinated the entire effort, because from there, there was a necessity to shift those who were positive to the hospitals. Like this, we use the available HR in the government to serve as the nodal officers. Officers from all the departments were taken for these purposes, whether it is general administration, whether it is police, whether it is forest service. We located who is able to deliver and included that person in the team. Like this, number of committees were made, number of nodal officers were selected who kept managing different areas for the containment of this disease. We also leverage the existing programs. One example will be, you might be knowing that Karnataka is pioneer in the country for mental health program. So we started the district mental health project way back in 1982 in Bellary. So that was started, forgotten, restarted 7-8 years ago. So fact remains that the state is pioneer in having this mental health program. In each district, there is a mental health team headed by a psychiatrist. There are clinical psychologists also, nurses, whole team is there. So this program was leveraged, and we started doing counseling to all those who were admitted in hospitals. It started with hospitals because at that point of time, a couple of people committed suicide. People were very afraid. I know a couple of people who were mildly symptomatic, they committed suicide. They would have come out after 2-3 days or 1 week. Such cases were happening. So there was necessity to counsel the public because things were unknown. And after that, when this lockdown started, the large number of people gathered, they were also suffering psychologically. So this program helped in counseling those also. So this was upscaled. And you will not believe, as on today, more than 9 lakh, about 1 million sessions have been held under this program. I am deliberately not giving numbers because it becomes very boring. And you lose the you lose the essence of you lose the macro picture, to say so. So more than 9 lakh sessions have been had. So then use of technology was also something which is manifested at its best in this control. So we are already having a program 104, Arogya Sahaya Vani, where anybody can call and get information. If somebody is having some symptom, that person can call 104 and inquire what I should do, I am having this problem. But it was having limited capacity. So with public-private participation, we started another one, 14410, Apt Mitra. This was named Apt Mitra. So here, some of the companies gave us their call centers, and initially they gave personnel also who were managing, but that could not be sustained for a long time. Then subsequently we employed personnel from the market, but the hardware as well as software was given by those countries. This is still continuing. So this, at different periods of time, this Apt Mitra has served different purposes. Initially, people were contacting because they were worried, okay, what is this disease? So a lot of calls were coming, inquiring about this disease and what are the symptoms, how to avoid, etc. Subsequently, we started health survey. We were the first in the country who surveyed all the households of the state. More than 1.6 crore households were surveyed to identify people with high comorbidity, pregnant and lactating women, people who are having severe comorbidities like cancer patient, tuberculosis patient, etc. We made a database and we started pushing calls from this Aptamitra. So all of them were contacted and they were advised, and we were inquiring whether somebody is having symptom or not. This also helped us in contacting those who were having some symptom. So from under Karnataka Private Medical Establishment Act and rules, we collected the data of the patients who were having ILI, SARI, etc. And we were getting this, we issued this notification, we started getting information from government hospitals and from private hospitals using KPME of the people suffering from especially lung diseases, ILI, SARI, and other comorbidities. And we started pushing calls from Aptamitra. And similarly, we went to the extent of collecting information from pharmacies of the people who are buying these antipyretic drugs. And we started pushing calls to them. So this technology helped in a big way. At the end of the day, we ended up with multiple softwares which created confusion. Then we rationalized. So we have contact tracing software, we have quarantine software, we have this Aptamitra, which is a big thing. And like this, for everything, there is a software. So so technology was leveraged in this way. So summary is that then I should not miss this public-private partnership. When we assess the requirement of beds, especially ICUs and ventilators, we realize that government is having, I mean, we have large number of beds in government system, but it is the private hospitals where you have more number of ICUs and ventilators. So it was inevitable that services of the entire system is made use of, whether it is lying in the government sector or in the private sector. So we entered into partnership with the private sector, and in the month of June we came out with this notification where rates were fixed, package rates were fixed for treatment in private hospitals. So that brought the private medical system, which generally 70% of the patients are dependent on this private system, they also brought into mainstream. It became a unitary system. There was a common system. We are the only state in the country, perhaps, where all the patients who came forward for government treatment, they were treated free. Even a millionaire came through the government system, he was treated free. Another thing which was seamless was that the person, depending on the availability of bed, was admitted either in government hospital or in private hospital without payment or co-payment in private hospital or whatsoever. So this seamless system was put in place. Of course, there were initial problems, and one of the first hospitals which came forward very positively is this institution. So I must congratulate the chairman and the CEO for this, that this is one of the hospitals which started many things early. It came forward with open heart and offered its beds. Then subsequently, when we were having surplus ventilators, this is the hospital which set the requisition of the first some 20 ventilators that were. So this institution has worked with the government very intimately and very sincerely. So that much I can say. So this system was put in place, and there is another thing that Karnataka did. When we found that this remdesivir is going to be of tremendous help, then remdesivir was given free of cost to all the government patients, whether they were being treated in government hospital or private hospital. We put an ingenious system of distribution where account is kept, because initially the price of one dose was more than 5,000 rupees. Now, of course, it has fallen to 1,800 or something. So that was also done. And I don't think anywhere in the country remdesivir has been given free. We have purchased almost more than almost 2 lakh almost 2 lakh remdesivir distributed. So these are some of the things we have done, but the fact remains that there was a great teamwork in Karnataka. Initially, Honorable CM was himself reviewing almost on a daily basis. Then he constituted a task force consisting of 4 ministers, 1 deputy CM and 3 ministers. And Chief Secretary took the leadership that greatly helped in interdepartmental coordination. And fortunately, our health team was very good. We had very nice officers in health. And fortunately, some of these officers, including me, were here for some time. We were not newly posted. We were knowing the department broadly. That helped us greatly. And I cannot name so many people, but it was really a great team. And a large number of initiatives which were started in Karnataka were replicated elsewhere in the country. So I will not go and count all of them, but this survey of all the household that was started, replicated elsewhere. Other states could not go to the extent of contacting all of them because the Apt Mitra type facility was not there. So we started fixing price of tests. That was also replicated in many states. Our 7th edition is over. We have revised the prices 7 times. We have ourselves got confused in lighter words. So these are some of the things that we did very broadly. And we are grateful to the people of Karnataka for showing great warmth, great support on all our endeavors, because we were fighting an unknown enemy. And we are fallible and we had committed mistakes. So I am grateful to everybody for forgetting the mistakes and giving us so much of, for being so grateful, giving us so much of warmth. And this type of cooperative sort of attitude has given us a strength to move forward. And I'm also grateful to those who were not part of the government, but they behaved like part of the government. And they spent long hours with us, even though it was not required, completely on honorary basis. So, having said so, I will again congratulate the organizers of this event. Maybe next year, if there is no COVID, still this will go on in hybrid mode. You might have realized the utility of going hybrid. So, you have best of both the worlds. Having said so, I thank all of you for giving me this opportunity, and I thank all of you for listening to me. Thank you very much.
Thank you, sir, for taking us through the very quick review of the measures taken by the government to tackle the pandemic of COVID-19. Moving on to the next proceedings, contribution of public health specialists for health is immense and limitless, right from the prevention to the rehabilitation of the patient. We take this opportunity to felicitate the public health specialists for their commendable contribution towards the public health. Now I hand over to Dr. Arjun and Dr. Dinesh for the further proceedings. I would request Javed Akhtar sir, C sir, Meeta ma'am, and Reddy sir to felicitate the honoraries.
We need to go there.
A very good afternoon, very good evening to one and all. We'll start our felicitation with our very own dear Professor C. Shivram. He has formerly served in the government of Karnataka for 23 years at various teaching posts at government medical colleges at Hubli, Bellary, and Bangalore. He served as Deputy Director for Medical Education and State Director of Medical Education for the past 2 years. He was former principal of MS Ramaiah Medical College, Bangalore for 8 years. He was a consultant with WHO, UNICEF and UPSC. He is also the founder chairperson of Healthcare Waste Management Cell in MSRMC, Bangalore. Tomorrow is Professor's birthday, so I would like to also wish him a very happy birthday in advance.
It's our honor and privilege to call on the next person, that is Dr. N. Srinivas Murthy. He is currently serving as the Research Director, Division of Research and Patents, Professor and Research Coordinator and Department of Community Medicine at Ramaiah Medical College. Started his career at Department of Preventive and Social Medicine, Institute of Medical Sciences, Banaras Hindu University, Varanasi as a faculty member. He's an adjunct professor in epidemiology at the University of Tampere. He joined ICMR in 1976 and served in various capacities at ICMR and its Institute of Cytology and Preventive Oncology, ICMR New Delhi. Presently, he is rendering his services as Research Director at the Division of Research and Patents. Dr. Murthy has published more than 215 research publications, and majority of them are in index and journals. He's already received many awards from NAMS Achyuta Award, and also he's got an award for his contribution in cancer research.
Well, the next person we want to felicitate is our dear Dr. S. Prithvish, who is from a HOD in Ramaiah Medical College. He's a member of the State Expert Committee on COVID Care in Karnataka, established in context of the Supreme Court directions. He's a consultant with UNICEF for MCH activities in India Country Office, New Delhi. The WHO International Expert Consultant in Indonesia, post-tsunami, with the WHO CERO, and Papua New Guinea with the WHO WPRO. Worked with Waste Netherlands in India and Sri Lanka. He was formerly associated with MSRMC as Head of Community Medicine and also with the GEF, UNIDO and MOEFCC initiative of environmentally sound management of waste.
Next is Dr. Suresh DK, currently working as a City Program Management Officer, National Urban Health Mission under Growth Bengaluru Nagara Palike, working as Deputy Health Officer Bobnalli Zone from 1st of Jan 2020, worked as Medical Officer Oil and Natural Gas Corporation, ONGC Bandra East.
I next welcome Dr. Manoranjan Hegde, Health Officer West BBMP. He's been working in BBMP since 1999 as Assistant Surgeon and in Public Health Department as Medical Officer of Health since 2000. Later promoted as Deputy Health Officer and Health Officer since 2013. He also worked as Chief Health Officer for 1 year. He was awarded the Kempe Gowda Award in BBMP for Best Medical Officer of Health.
Next, I would welcome Dr. Suresh Shastri, who has worked very passionately, currently working in the Department of Health and Family Welfare since 21 years. Pathologist and HIV fellow from the University of Washington, head of Ayushman Bharat, Arogya Karnataka Cell in Commissionerate, and also as a joint director IEC. He holds 5 designations: Senior Specialist TB, Joint Director in charge CST in KSAPS, State Nodal Officer National Viral Hepatitis Control Program, Joint Director in charge BARC Cell, and Director in charge IEC.
I would next like to welcome one more of the senior members of the community medicine fraternity, Dr. Angadi. He's professor and head of community medicine at Sridevi Institute of Medical Sciences and Research, Tumkur. He successfully organized a 2-week field epidemiological training program for 4 batches of district surveillance medical officers of Andhra Pradesh, Chhattisgarh, Kerala and Tamil Nadu, sponsored by Center of Disease Control, New Delhi. He's published many research papers in international and national journals. He has conducted many health camps and health awareness programs in rural areas, urban slums, and schools and colleges.
Next, it's my honor and privilege again to welcome Dr. Jayachandra Rao. His achievements of being in charge of Swachh Bangalore project. He has been associated with measles immunization program in association with UNICEF. Under the World Bank project, he has been successful in establishing 55 plus 50 health centers, training come health research centers, upgraded 24 maternity homes, 5 referral hospitals, 7 set quarters, ambulances, etc. in Bangalore city. He has also served as a chief health officer, BBMP, pioneering work in biomedical waste management responsible for the rules to come into effect in India.
I next call upon another senior fraternity from the Department for Community Medicine, Dr. Sharda Machaya. At present, she is on COVID helpline. She does health checkups in orphanages and elderly care centers. Formerly involved in the National AIDS Control Program, tuberculosis, leprosy, and other infectious disease of national importance for training of personnel and other associated activities. She is a core committee member of the RNTCP. She is chairperson of Medical Education Cell, Union Public Service Commission, and state subject expert for selection of doctors for central government services, railways, medical colleges in India and Karnataka. Madam was also the former HOD of the Department of Community Medicine from BMC.
Next, it's my honor and privilege to invite and welcome Dr. Ravi. He's a retired professor, former professor of head and head of neurovirology in IMANS, member State Technical Advisory Committee, Government of Karnataka for COVID-19 response. His areas of interest are public health virology, Japanese encephalitis, acute encephalitis syndrome, development of indigenous kits, antiretroviral therapy, immunology, and pathogenesis of viral infections of CNS, psychoneuroimmunology.
It gives me great honor to next call upon Dr. M.K. Sudarshan, Chairman, State Technical Advisory Committee, Government of Karnataka for COVID-19 response. He is former professor and head of Rajiv Gandhi Institute of Public Health and Center for Disease Control. He retired as Principal and Dean and Professor of Community Medicine from Kempegowda Institute of Medical Sciences, Bangalore. He is a member of the WHO Expert Advisory Panel and consultations on rabies. He's the Global Alliance for Vaccine and Immunization, Switzerland, and Government of India Expert Committee member on rabies.
Not to forget the contribution of our staff nurses who have served as a COVID warriors in true sense and have rendered their services in the COVID wards 24/7. We now take this opportunity to honor the staff nurses for their contribution. May I now call upon Mr. Vasant. Now I call upon Jansi Mary. Yes, sir. Thank you, dignitaries, for doing the honors.
Oh, that's in the quarters. Okay.
Thank you, Dr. Dinesh and Dr. Arj. Moving on to the next session, the most awaited session by the presenters in this conference. Now I request Lalita ma'am to announce the awards for the scientific sessions.
Thank you, Pavitra. There were in total of 83 PG presentations, 6 UG presentations, 43 faculty presentations, and so this was a presentation which we had to have 26 panel presentations. So we'll move on to the award category. The first is the overall best oral paper category. Do you have the PPT? Plate. First, okay, we'll go with first Catch Millennium Award. UG category. Winner we have Kiran R from Ramaiah Medical College, Mangalore. And runner-up Sai Kishan Sasikumar Menon from Siddhartha Medical College, Tumkur. Postgraduate category Dr. Sai Srivalli Sripada, Katuri Medical College from Guntur. And from faculty category Dr. Prachit from Ramaiah Medical College, Mangalore. So these were the Catch Millennium Award, which had full paper submitted along with the presentation which was evaluated by the judges. Next, from the oral paper presentations, UG category, Anu KM from Gadag Institute of Medical Sciences won the best oral paper presentation. And PG, we had many papers, so we decided to have 2 awards. Winner is Dr. Sunita Velamela from KS Egde Medical Academy, Mangalore. Runner-up, Dr. Neha D'Souza from Bangalore Medical College. And faculty thematic category, we have winner Dr. Pavitra Chaluraj, Ramaiah Medical College. Anyway, since she is present in person, we can hand over the prize for her. Pavitra over here. Here, come. Javadar, sir. I request sir to please hand over the prize. Sir. And faculty thematic category runner-up, Dr. Pradeep Tarikere Satyanarayana from Sri Devaraj Aras Academy of Higher Education and Research, Kolar. And PG non-thematic category winner is Dr. Ajit Dio Burma from NIMHANS. And runner-up is Dr. Thomas C. Davis from St. John's Medical College, Bangalore. Again, faculty non-thematic category winner is Dr. Akshaya KM from Ramaiah Medical College, Bangalore. And runner-up is Dr. Ishfaq Nazir Bhatt, who is from Kanachur Institute of Medical Sciences, Mangalore. And best poster, PG poster, Dr. Shweta Neminath from Kurkuri, for Vaidehi Institute of Medical Sciences, Bangalore. And again, Dr. Prachet has got the best faculty award for poster presentation from Ramaiah Medical College, Mangalore. And for all the paper presentation and poster, we had 2 judges who had anonymously evaluated and given the award. For the video contest, we had 9 entries, but looking at the reviewing, but the reviewers felt they could give three prizes. Third place goes to Dr. Santosh Achappa from CDSIMER. And 2 consolation prizes, that is Mr. Venkata Rishabh and Mr. Agil Somasundaram. Venkata Rishabh from WIMS RC, that is Vaidehi Institute of Medical Sciences, and Mr. Ajit Somasundar from NMC. Thank you.
Thank you, ma'am, and congratulations to all the people who have got the award.
We will reach the courier all the awards to the winners, which will also carry the cash prize of 1,000 rupees for the first prize and the 500 rupees from the second runner-up place. Thank you. With the certificate.
I now request the catch office bearers to give their opinion regarding CatchCon 2020.
Very good evening to all of you. So, on behalf of the CATCH, as the president of the CATCH, it's my great pleasure to thank the Javadar sir, who has presided over the today's valedictory function, and Srinivas Murthy sir for presiding over the function, and Dr. Medha Rao madam and Dr. Ramakrishna Reddy sir. And also I am thankful for the great over the elders and founders of the CATCH, Dr. Sudarshan and Dr. Shriram sir, who are present on this occasion. So we are very grateful to you, sir. And then Dr. Lalita has read about the proceedings of all the 3 days this thing. And from the proceedings, all of you know that the 3 days the CATCH conference was very fruitful. And without taking much time, and also now it is by 10 o'clock, the curfew is going to start. I thank one and all who are responsible for the, and also I thank especially the management, MS Ramaiah College, the thing, and then the organizers of the Department of Community Medicine on this occasion. Thank you one and all.
Sir, vote of thanks is here.
Thank you, sir.
There are really there, but specifically, sir, Government of Karnataka and why Riyaz ಅವರು ಏನು ಹೇಳ್ತಿದ್ದಾರೆ, Rajiv Gandhi University and Government of Karnataka, along with our management, the 3 of them literally came where we needn't had to go out for any sponsorship, sir. Thanks to Srinivas Murthy sir and our college management, the entire infrastructure was provided for this hybrid conference. And I'm doing an informal vote of thanks. And the government of Karnataka, sir, from Pankaj Pandey sir's office, Arundhati ma'am. In the last 1 year where we had worked alongside the government, as you told, we never felt that we were outside as a private this thing. It was a single team effort, and many in this room have in some way contributed for this fight against COVID, and we worked as a team without knowing whether we were in private or in government. So I thank the government, Rajiv Gandhi University of Health Sciences, and Ramakrishna Reddy sir, Sachidanand sir, because wherever we went and asked for any support, it was met with an yes. We were never told that like we will see or we need to wait. It was met with an yes, and hopefully in the last 3 days we have made that commitment and tried to make this hybrid conference with the numbers that what madam is mentioning, and it was not a simple task. The IT team of the Ramaiah Medical College, and we had representation from Black Deal, which is an agency which is helping us in live streaming this to across India and beyond. So we had participants from US, UK in the live panel discussions. So it has been a Herculean task with almost 85 names I have on this list and many others. So for the paucity of time, all the people who have not been mentioned by name, not that they are not any less important, all the people, our community medicine team and the rest of the catch office bearers and everyone have made this event a very huge success. And we look forward to take the proceedings in a form of video documentary and a white paper, which would be present in years to come as a sort of like learning for us to do things better and in a much larger manner. So thanks a lot for everyone, sir. Sir.
You know, what has happened during the last few months, it has been such a great degree of mobilization of all kinds of people, all departments in government, educational institutions, various departments. Everybody has come together to participate in the assigned task, performing the assigned task in fighting this pandemic. This is one of those extremely rare things to have happened. As far as I say, I have served 40 years in public life and in various capacities, including as Commissioner of the City Corporation. Never have I seen anything of this kind of mobilization of the entire society to fight a common enemy. This needs to be documented in all its detail. And if you are able to do that, it'll be a great service for the posterity. Maybe your catch could, because this is a public health issue, you could take it upon yourselves to do this, travel the entire state, meet all the important people who have participated in this, talk to all the department people, talk to all the NGOs who have worked, talk to the citizens, talk to the patients, and prepare documentation which will be a reference for any touchwood eventuality in the future which we may face, not only here but anywhere else in the country or in the world. Thank you very much for this opportunity. Yes, thank you. Thank
you. Thank you so much. And that is one of the objective of conducting this conference, and that will be the outcome of this conference. And we are already at it, and we have taken the response of BBMP, Government of Karnataka, and also as a district response, Chikbalapur as a model, we have taken from the DC to the Anganwadi Asha worker response has been documented. We'll go further beyond and document, sir. So I thank each one of you here who have joined us in person and on offline as well for this conference. At this moment, I take privilege to honor our chief guest, Mr. Javed Akhtar, sir. Sir, I request you to hand over the momentum from our side. Unfortunately, Dr. Pankaj Pandey sir also was supposed to join us because of some other commitment. He is not able to join us. We thank him for all the support. And on behalf of the Rajiv Gandhi University, we have today Dr. Ramakrishna Reddy, who is the Registrar Evaluation. Sir, thank you. And also he is from Community Medicine BMC as well. Sir, please can you accept the memento from our end? We have some other guests who are always behind and helping us. Dr. Riaz, please accept a memento from our end. And our registrars also, Dr. Pratap and Dr. Hemant. Hemant is anyway our member. We can give him later. At least Dr. Pratap, sir, please join us.
Sir, on a lighter note, all of us call ourselves as PG plus, Tata Sky plus, sir. PGs of this institution.
Pratap, sir, and please come.
Riaz, Dr. Hemant, Dr. Suman, Dr. Girish, who leads the thing. So we have been postgraduates of Ramaiah.
Hemant, please come.
Continuing over here, sir. As students of
Okay. Huh? Two more. Come on. We will, last but not the least, Dr. Dayanand sir and Dr. Ranganath, who is the president and secretary, who have been backbone of this conference from the catch. Please, sir, please do come. Girish sir. And last but not the least, I think my team, young and old, everyone, I think they have toiled hard and they stood with me to run this program. I thank each one of both my faculty, PG and non-teaching faculty. They are the strength for me. That team has worked and that is the result of this. I thank each one of you. Sincerely, if give me 2 minutes, I can call them also by name, sir. Because there are lots of us. Dr. Shalini Pradeep, please do come. We'll not, or we'll have a photo with our team, sir. Okay. Dr. Shalini Pradeep, I'll just introduce my team. Dr. Shalini Pradeep, Dr. Dinesh, Dr. Arjun, Dr. Suman, Dr. Nandakumar Yosi, Dr. Murthy sir also is there. Thank you. Dr. Anantram, Dr. Priyadarshini, Dr. Babita, she's always behind. Pavitra, Dr. Pavitra, and our PGs, Dr. Bhavna, Dr. Akila, Dr. Divya, Dr. Ashwini, and one more person, Dr. Manasa, Yashashwini and Manasa. Our MSWs, Mr. Dinesh, who is not there today, and Rakesh. Yes, Arjun is here. Thank you, each one of you. I fall short of words or anything. Thank you all is what I can say. Thank you. We'll break for the session. Kindly join us for dinner at MEC room.
I request everybody to rise for national anthem.
Miss Shalini Nui, she's on the vice principal side.
Punjab, Sindh, Gujarat, Karabanga, Vindhya, Himachal, Yamuna, Ganga, Ujjala, Jalavi, Taranga. तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगल गायक, जय हे भारत भाग्य विधाता, जय हे, जय हे, जय हे, जय 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 हे, जन गण मन अधिनायक, जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा, उज्जल जलधि तरंगा। तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगल गायक, जय हे भारत भाग्य विधाता, जय हे, जय हे, जय हे, जय